Terrific. Okay. Dr. Korthus, is it Korthus? Did I just say that? Can you hear us?
Yes.
Oh, excellent. Okay. All right, everybody. Things have gotten just better. That's all. Okay, so I believe I'm going to turn this over right now to Morgan Godwin, and you're going to go. You're going first.
Sure.
Morgan. Okay. And then we'll turn it over to the good doctor. Go ahead and introduce yourself and talk to us.
Hello, my name is Morgan Godwin, substance use and drug policy researcher. I also serve on various state committees, but I am here before you talking today just as me. Can we go to the next slide, please? There are my various affiliations. All right. Addiction is defined as continued use despite repeated negative consequences. That is why when I was in the depths of addiction, I couldn't simply stop, no matter how much I wanted to. I thought if I created a life worth living, then and only then I would stop using. So I got myself into school. I got my EMT license and I was continuing on for my paramedic. I had a full-time job delivering pizza, yet my drug use continued and it was negatively impacting my life. Next slide, please. When I was finally arrested, still in my Domino's Pizza work uniform, I was offered diversion in the form of drug court. I had the privilege to get myself into inpatient treatment, not because it was anything offered by the courts, but because I had private health care and could get into a facility that did not accept Medicaid. And when I got out, After 28 days, I relapsed immediately. But I did not want a felony. I would lose my EMT license, and all of my college credits would become worthless. Finally, I got on Suboxone. It had never been offered to me in multiple stints in inpatient, not by the courts, no one, even though it is the gold standard medication for opioid use disorder. I was frustrated by my lack of willpower, and I wanted to take it out of the equation. So I hatched a plan. I asked my doctor for a letter stating the importance of Suboxone and imploring the courts to keep me on it. I then went before my weekly drug court check-in. Next slide, please. You can tell because I left my hair down and did my makeup and took the max so my car wouldn't get impounded. And I stepped up to the podium and asked to be taken into custody. "What a brave thing to do," said Judge Ryan as the bailiff gathered up my things, the Suboxone and the letter. When I finally saw a nurse at Inverness Jail and asked for my medication, she scoffed at my request. They do not offer Suboxone. 10 years later, they still do not universally offer Suboxone in the jail, much less our other 35 counties. Buprenorphine, the generic name for Suboxone, increases the 5-year survival rate by 50%. If this were a cancer drug, it would be hailed a miracle, but because it is for addiction, it is still stigmatized. I was forced to kick cold turkey in an open dorm, writhing under fluorescent lights that never turned off, throwing up into a trash can while 77 other women looked on. And for every minute of that agony, I had to remind myself that I had asked for it. I was released back into the exact same circumstances, a little more bitter and a lot more traumatized, and I relapsed immediately. Oregonians are 13 times more likely to overdose and die after even brief incarcerations. Within a month, I was incarcerated again. Next slide. You see it as wildly, okay, fine. You see it as wildly dishonest to frame diversion programs as if they are not incarceration. For the majority of people placed in them for simple drug possession, just like the drug court I experienced, we will end up in jail because we were not able to stop for all the myriad natural consequences we have faced, and so adding the additional consequence of the criminal justice system doesn't mean we can magically stop then. It is the literal definition of addiction to continue using despite negative consequences, whether that is the threat of jail or the destruction of your interpersonal relationships. After going to jail twice in a month, I was fired from my job, I withdrew from all my classes, I lost my income and my military education benefits. I also lost my reason to sleep regularly, shower, or pretend to be a normal member of society. I was jobless and homeless, though never tent homeless, because back then it was easy to find a room for rent for $300, and anyone can pay their rent if it's cheap enough, which meant I always had a friend to stay with. By my next arrest, which I swear I had a slide for. Can I go to the previous slide? No, okay. Maybe not. By my next arrest, I had lost 15 pounds, been up for days on an injection cocaine binge, and finally I was just given the felony. I resigned myself to a life and death in heroin addiction. It is dishonest to say that people have not been getting incarcerated for drug possession in Oregon for such a long time just because we were not going to prison. The state of Oregon took 60 days of my life for the high crime of possessing small quantities of drugs. A few months later, I acted as a middleman for one of my best friends. He overdosed and died alone in his apartment, and I was sentenced to 5 years in federal prison, pled down from drug delivery resulting in death. With addiction and overdose having touched every facet of my life, I got out of prison and dedicated my entire life to overdose prevention, immediately enrolling in the OHSU PSU School of Public Health, and thus began my drug policy expertise. Next slide. Next slide.
You do have that.
My slides got out of order. Okay, there's my drug possession binge. Next slide. All right. In 2017, This is a chart from 2017. Fentanyl was already ravaging the East Coast and making a terrifying westward march. There, it first came as an adulterant in the heroin supply, coexisting alongside heroin for several years before replacing it entirely. Here, we were sounding the alarm bells, but Oregon sat on its haunches, content ranking last or next to last in access to addiction treatment, as the greatest public health threat we have ever known was knocking on our back door. The Pacific Northwest was the last region in the country to get fentanyl. Black tar heroin, unique to the West, wasn't as easy to adulterate with white powder fentanyl. So when it arrived here, it arrived as fentanyl in the form of counterfeit pills. It was the fastest transition from a total heroin market to a total fentanyl market anywhere in the nation. Next slide, please. Legislators and law enforcement all acted surprised, like it came out of the blue, like we hadn't been warning of this all along. Measure 110 was the first massive infusion into our substance use infrastructure when it was never more needed. Today, Oregon ranks number 26 in the nation for our fatal overdose rate, well below the national average, even though we have some of the same elevated rates of substance use disorder that have plagued us for over a decade. Fewer of our overdoses become fatal when compared to other states. We have a high overdose reversal rate. Part of that is our harm reduction coverage, and some of that is due to the fact that people here are less likely to use alone. Most fatal overdoses occur when people are home alone. People experiencing homelessness would rather not be using drugs in public, but what I've heard is that it's preferable to do that than dying alone in their tent where they wouldn't be found for days. Despite shattering law enforcement seizure records every year, the price of drugs continues to fall while all other consumer goods experience inflation. It is true that Portugal's orientation towards reducing the risks and harms associated with drug use is profoundly distinct from our singular focus of eradicating drugs from the nation. One of these approaches is based in reality, and the other is not. After $1 trillion invested in the drug war and an ever-growing budget for the DEA and CBP to focus on drug interdiction, bottom rate prices are predicted to be halved within the next 5 years. Drugs are continuing to get cheaper, which means they are more available. Where there is voracious demand, there will always be supply. These are the laws of capitalism. Instead of reducing harms, we cling to a fantasy of drug eradication, letting our ideals get in the way of true solutions. Oregon's overdose rate remains low, much lower than Washington that had promptly recriminalized drugs after their brief decriminalization. Next slide, please. What do the states with the highest rate of overdose have in common? Almost nothing. This is a comparison with their incarceration rate, and you can see it's all over the map, with Louisiana being the most carceral state in the nation and Maine one of the lowest. The overdose crisis didn't magically appear with fentanyl. I buried my first friend in 2011. The U.S. has identified itself as being in an overdose crisis for 2 decades. For those of you who only recently started paying attention, let me remind you that we had tragic levels of overdose long before fentanyl arrived, since the days of felony drug possession arrests here. There is not more addiction on our streets. Next slide, please. Oregon's substance use disorder rate has remained fairly constant, increasing only 5% since 2019, on par nationally since the COVID-19 pandemic spurred a lot of relapses. But an explosion of homelessness since the pandemic means that those who used to suffer behind closed doors are now suffering in our line of sight, and that makes us deeply uncomfortable. Not only is addiction more visible, it's worse. The acuity of substance use disorders has increased exponentially, which is complicating treatment. People with schizophrenia so severe that they're covered in their own filth cannot be involuntarily committed because Oregon standards are so high. Psychosis, unlike addiction, is actually more prevalent on our streets. which contributes to the feel of disorder. Yet we're not having that conversation. Instead, we are talking about putting people like me, who possess small amounts of drugs and do not commit other crimes, in jail. You will end up in jail if you continue using once being placed in a diversion program. If that person is unable or unwilling to find recovery in that moment, they will psychologically associate both treatment and recovery with handcuffs in jail. It took me years to unwind that association in my mind and voluntarily engage with treatment and recovery again. We squandered the decade we had to prepare for fentanyl's arrival from when it first appeared on the East Coast. And now we are squandering a legislative session, squabbling over whether we should coerce people into treatment, when there aren't anywhere near the amount of beds available right now for the people that are asking for them, begging for them. And we are talking about putting people who don't want to be there in direct competition for those beds from people who are seeking them. Do we not have a moral and ethical duty to supply treatment for all those who desire it? We are debating that which is not up for debate. Decriminalization is scientifically sound. The science on it is settled. Arrest and incarceration produce harms, and incarceration or the threat of incarceration does not reduce a state's level of substance use. This is evidenced by the fact that the 25 states with higher overdose rates all arrest people for drug possession. That decades of threatening drug users with incarceration has left us with the highest OD rate in the entire world. Our OD rate is 20 times that of the global average. And this is not to mention the decades upon decades of scientific research that prove incarceration is not an effective intervention for substance use. We do have solutions. This is not to despair. Medications for opioid use disorder are proven to be effective. Housing is proven to be effective. Weaving in peer mentoring with supportive housing is effective. We know how to treat opioid use disorder. In fact, we treat that better than stimulants. Although what we are seeing on our streets right now is a polysubstance crisis, where most people dying of fentanyl also have methamphetamine in their system, and that so often gets left out of the conversation because of the panic around fentanyl. I'm sitting before you today, successful, not because of my incarceration, but despite it. Thank you.
Thank you very much. I appreciate that. There are a few more slides that have been uploaded onto OLS as well. So, all right. Thank you so much. Doctor, you're up next.
Our streets right now is a polysubstance.
Hi, can you hear me?
I can. And for those of you who are on, if you could just go off camera if you're not speaking, that would be terrific.
Wonderful. And can everybody see my slides?
Not yet. Hang on.
Actually, something is.
Hang on. Yeah, just a second. We're having some technology issues.
And I can share my slides, right?
Dr. Corthius, yeah, you have been, this is Brian, you've been made presenter to be able to share your slides. We can also pull them up if you are unable to. We have them as well.
No, I have them here. Can you see them, though?
We can't.
No, we cannot
cannot
see
see
them.
Try to share our screen again. It says I'm sharing.
Well, why don't we do this? Why don't we try to pull them up on our end?
Try one more
Oh,
time.
there they are. I don't know who's done it. All right, so we did it. I think we did it.
It's magic.
All right, so I think you'll just have to let us know when you want to advance them.
Okay, so I'm controlling the slides or no?
I do not believe you're controlling the slides. We are.
All right. Okay, well, we'll work that. All right, well,
Go ahead and tell us your
Thank you.
name for the record, and go ahead with your testimony. Thank you.
wonderful. I'm Dr. Todd Korthus. I'm head of addiction medicine section at OHSU. And thank you so much to the committee members for taking the time to address this issue. And to my friend Morgan Godwin for really setting a beautiful stage for what's going to come next here. Next slide. So when we look at rates of change, this is the most recent data from the CDC that predicts that 1,511 Oregonians will die in the current 12-month period. And this is a 26% increase over deaths last year. So even though Oregon has a lower overall overdose rate than some states, we are on a rapid increase, and that increase has been year over year, going back over a decade, but it's really escalated lately. Next slide. When we look at what's driving this, this is very recently updated data from the Oregon Health Authority. Thank you, OHA. Where you can see in the orange line, it's really fentanyl that is driving this, along with increases in methamphetamine that go back at least to early 2020. And that fentanyl deaths exceeded methamphetamine-associated deaths for the first time in 2022. Next slide. So one of the things that I worry is, can you see the animation or?
No, and Doctor, we're going to need to, I see you've got about 34 slides here, so we're going to need to, I don't want to rush you too much, but we've got a lot ahead of us.
Yeah, I can get through this in 15 minutes.
Okay.
It'll be faster with no animation now. So at any rate, so not all drugs are equal is the bottom line here. And I think that's sometimes lost in the decriminalization discussion. We have, this is data from Australia that ranks harms to the individual in blue over harms to the community in red. And we see on the left of the screen, alcohol and crystal meth, at least in Australia, are really driving harms, whereas cannabis is somewhere in the middle and psychedelics are dead last. Fentanyl, however, is really more on par with alcohol and methamphetamine harms. And I would just argue that now the discussion is fentanyl, but we need to build systems and policies that will apply to the next 6 fentanyls that are sure to come as time goes on. Next slide. Why is fentanyl different? It's synthesized labs as compared with heroin that's derived from poppies. This makes it cheaper and easier to buy. It activates opioid immune receptors, which is responsible for its effects 50 times more potently than heroin. It's shorter acting, lasting about 1 to 2 hours, and this means people need to take it every 1 to 2 hours in order to avoid withdrawal symptoms. It's also lipophilic, meaning it builds up in the body and lasts longer, even after you stop. All of this leads to a much more addictive opioid than we've seen before, that it results in longer and more intense withdrawal symptoms and makes it more difficult to stay in recovery. Next slide. Okay. Another trend that has happened is, when I started doing this 18, 20 years ago, there were people who used opioids and people who used methamphetamine, and a little bit of overlap. Next slide. That's changed. In a recent survey of rural Oregonians who injected drugs, 98% of those using opioids also used methamphetamine. In addition to flooding our state hospital with the increased mental health consequences of methamphetamine, these individuals reported triple the odds of overdosing in the previous 6 months. Next slide. But not everyone bears the burden of overdose in Oregon equally. Our Black and American Indian Oregonians are overdosing in more than twice the rate as white Oregonians. And as a community, we need to come together to address the underlying structural racism that perpetuates this. And I want to call out Miracles Club, that's really embracing Oregon's Black community, and Painted Horse Recovery that's doing the same for our Native American community that's trying to reverse this trend. Next slide. Incarceration and drug use is also an issue in our rural communities. This is data that was just published 2 weeks ago by Dr. Hoover and our team. We surveyed people who were using drugs in rural Oregon and 9 other states. 42% reported being recently incarcerated. And of these, 85% reported opioid use, but only 18% had received medications for opioid use disorder. And the bottom line here is, as Morgan said, we need to think about ways to better expand access to medications for opioid use disorder, both for our folks who are entering incarceration and those leaving. Next slide. Another at-risk group are adolescents and young adults. Oregon has the fastest growing youth drug death rate in the US. Next slide. And there are 2 groups that are at risk. One are teenagers who are doing what teenagers do. They're taking risks and experimenting. And the intervention here is prevention. Then there are kids whose use has gotten out of control, and they need individualized treatment for use disorder. And unfortunately, another recently published OHSU study demonstrates that treatment is frighteningly scarce. Next slide. So when we think about solutions, it's important to tailor them to the spectrum of use. So among people who haven't yet started using, it's all about prevention. And then we apply treatment and harm reduction to various levels of use in preparation for quitting. Next slide. And I would challenge us to view policy solutions through the lens of Martin Luther King's beloved community that prioritizes just and equitable structural systems that bring together persons in a community rather than completely focus on individuals. And for addiction interventions, I think this thing means 3 things. It means decreasing drug use, it means decreasing community harms, and it means decreasing incarceration, which, as you heard from Morgan, is the least effective approach. Next slide. So I'm going to really rank all of the next 6 interventions through this lens. The first goal is prevention, the goal of which is to decrease the number of people who are starting to use drugs. And one great example of this in Oregon is the Beaverton School District's Fake and Fatal program that's raising awareness among teenagers. And since they've had a single overdose in the school district, as well as school-based programs that build resilience and life skills. This hits all 3 of the trifecta for a beloved community. Next slide. Prevention also has the advantage of having the biggest bang for the buck in its application to our 4.2 million Oregonians. Prevention is going to be the most cost efficient. Next slide. The next intervention that works are medications. We have 3 that are FDA approved, but really buprenorphine and methadone are the ones driving this, and all of these achieve all 3 goals here. Next slide. Looking at the effect on mortality, we see in blue people who are in treatment on buprenorphine and people who aren't in orange, and you can see that being in treatment with buprenorphine decreases all-cause and overdose mortality by at least 60%. Next slide. And the same thing is true even more so, about 80% decrease in mortality with methadone, which is our most effective treatment in the fentanyl era. Next slide. We've accomplished a few great things in Oregon with methadone by expanding the number of opioid treatment programs. And I'm super grateful to the Confederated Tribes of Grand Ronde, who've opened 2 of these recently, as well as 5 new OTPs in the Oregon Recovery Treatment Centers. We also have 2 mobile methadone vans, one of which is being piloted by Grand Ronde. However, we have a lot of challenges to upscaling this. Methadone is typically high barrier. We have limited access in our rural counties. There are typically long waits, and the relaxed policies that were demonstrated to be safe during COVID for staying on methadone are being rolled back in some opioid treatment centers. And I think there's opportunity to put a legislative stop to that. There's also a lack of coordination with hospitals, skilled nursing facilities, and integration of methamphetamine treatment in some. Next slide. The next intervention that works is harm reduction, the goal of which is to improve safety and decrease harms for people who are using drugs on their way to not using drugs. And we have naloxone, syringe service programs, fentanyl test strips, and medical care for infections and things in this category. This clearly reduces harms to the individual. It decreases harms to the community by decreasing the cost to Medicaid of hospitalizations that are related to injection drug use, which is actually the sixth most highest cost of healthcare in Oregon. And it's a little unclear how this decreases incarceration, but it may. Next slide. We know that in the state of Massachusetts, communities that implemented widespread adoption of naloxone reduced their overdose rates by 46%. But the challenge is getting it to the people who need it when they need it. Next slide. And this is a great Oregon success story. The Save Lives Oregon initiative is a statewide clearinghouse for distribution that's delivered 335,000 doses across Oregon in the last almost 2 years, and documented at least 3,100 bystander overdose reversals since 2022. We need to continue supporting this. Next slide. However, harm reduction also involves reducing harms to our communities, and this starts, in my mind, with expanding affordable housing to decrease homelessness, which is really the primary barrier to entering and staying in treatment. And also decreasing crime in our communities, supporting our families, and creating safe environments for schools and businesses. Next slide. Another intervention that works is external pressure. And I know this is controversial, but I just want to put some data on the table because this is one of the 6 interventions that does all 3 things when done right. We know that mandatory treatment for healthcare providers and airline pilots actually achieve the highest quit rates and job retention rates in the industry. We know that drug courts actually, on average, decrease drug use and recidivism by about 12%. Could be better. And there's frequently a ball that's dropped in the handoff to community-based treatment that we need. There are also programs like the 24/7 sobriety program that actually have been well studied and decrease the risk of death in people with repeat drunk driving by 50%. So this is another one that's hitting the trifecta. Next slide. The next intervention, and this is my favorite, that works are peer support specialists. I really view these as the secret sauce, the link between use and treatment. The Oregon Hope Peer Engagement Initiative recruited peers with lived experience in recovery to actively recruit people who were using drugs in our rural counties, and they weren't looking to be enrolled in treatment. Their goal was to make friends. We enrolled 605 people using drugs, 78% of whom accepted peer services within 3 months of the first contact, 13% of whom engaged in substance use disorder treatment within 3 months of meeting the peer for the first time. And I want to highlight this as this harm reduction activity that's grounded in the community is actually having a dramatic effect on increasing treatment engagement. And this has since been expanded by Oregon Health Authority to Prime Plus in 24 of Oregon's 36 counties. It's also serving as a platform for overdose prevention and methamphetamine initiatives, clearly hitting all 3 of our beloved community goals. Next slide. And if I haven't already said it, the spectrum of care needs addressed within every aspect of the community. I would argue, including our schools, our churches, law enforcement, healthcare. And next slide, last slide. And this is how we will do the very, very, very hard work of achieving a beloved community in Oregon through at least these 6 and others that I haven't spent time on, interventions that decrease drug use harms to the individual, decrease community harms, and decrease incarceration. Thank you very much.
Great. Thank you so much, Dr. Colleagues, questions? Yes,
Thank you,
Representative
Chair.
Nose.
Just one real quick one. So, Doctor, the slide about mandating treatment sparked a question for me.
Yeah.
Some of the critics of ballot measure 110 want to mandate that people that are living on the streets with addiction, using in public, be required to go get treatment as opposed to, say, being dropped off at a jail site. Do you have any insight as to whether or not that will work? Because other people I listen to think that a sort of mandatory treatment approach isn't going to be as successful as we might think it should be.
That's such an important question.
Okay, good. I'm glad.
And the answer is complicated.
Okay.
I think it's really important to remember Morgan's story. If you're going to have external forces of any kind encouraging treatment, you got to make sure there's treatment to be had.
Okay.
And so I think that's the starting point. Clearly, treatment is going to be more effective than incarcerating anyone. However, I do believe that there's a role for law enforcement in our communities that specifically in the context of diversion programs can achieve success. And this is what happens in places like Portugal, and I would argue Spain, is decriminalization doesn't happen in a box. They have it happen in the context of a national healthcare system that supports engagement and treatment and does direct link to care from their diversion programs.
Okay, thank you.
All right, thank you, Representative Mannix.
Thank you. Underlying all of this, let's set aside several other issues. But what I've heard continuously is we lack facilities, I mean physical facilities, to provide the treatment programs. And I would ask you whether or not returning to use of some of our state facilities which are currently vacant might help. For example, across the street from the current state hospital is what has historically been called the Dome Building, which was built in 1910, still standing, fully functional, 67,000 square feet. At one point it housed about 500 people in a hospital setting until it was turned over to the Department of Corrections to be an administrative building. Would we be in a good position if we had a facility where we said you can be treated in-house, provided with what I'll call a hospital setting as opposed to a jail setting as an early intervention? And maybe that's too broad a question, but I want to throw it at you.
I think all creative ideas are on the table at this point, and I applaud the creativity. I would also point the committee to the gaps analysis that was conducted by PSU, OHSU, School of Public Health, that demonstrated that actually in our existing residential treatment programs, they were only active about 50% capacity of their bed capacity due to staffing issues. And the more we can do to support hiring and retention of staffing for those facilities, the better. The other thing I would say is not all addiction treatment, in fact, only a fraction of addiction treatment is residential. We need to build out our outpatient programs, and I'm encouraged by programs that actually start with outpatient and use residential as the backup plan B if plan A doesn't work. The final point I'd make on residential expansion is we need it for everyone. There are more adults than kids, but we really need this for kids. There are clearly not enough adolescent beds. And we also need to expand adolescent treatment potential by supporting our family medicine and pediatrician colleagues to adopt this in their practices as outpatients.
All right, one follow-up. Go ahead,
I'm
Representative.
not presenting this as an alternative to everything else. I'm presenting it as a supplement. So if Morgan Godwin came in and she said, I need treatment, and I'm asking for treatment, wouldn't it have been helpful if we said, we have a facility where you can be admitted and you can live there, and it will be a controlled environment, but you will be provided with treatment in this facility, as opposed to a jail.
I think anytime we put a roof over people's heads and offer them a safe place for recovery, that's a win. And I would also say that another rapid access success story in Oregon is the Harbor Clinic at OHSU. That's a telemedicine bridge clinic where people can call in and get on buprenorphine typically the same day. And a lot of our peers actually use that in the field. They'll talk with somebody and say, "Oh, you want bup? Here, call this number."
Thank you.
All right,
Thank you.
colleagues. Thank you so much, Dr. Morgan. Thank you very much for your testimony. We're going to move on to our next informational speakers. We're going to talk about medication-assisted treatment. I'm going to call Moxie Loeffler to hear Lieutenant James Russell and Sergeant Marie Gaynor. Why don't you all three come on up? We're going to, who's remote? Oh, Lincoln County folks are remote. All right. It's Dr. Loeffler up here. Okay. And really, one of the things we want to focus on here is what policy changes might the state need in order for us to have medication more available in our communities. All right, Dr. Loeffler.
Good morning, Senator Lieber and Representative Kropf, the chairs of the committee, and also to the rest of you. Thank you so much for having me here today. I live in Eugene, Oregon, and I am the public policy chair for Oregon Society of Addiction Medicine. We're a chapter of ASAM, and we have over 100 member physicians. And I'm also the Oregon Medical Director for an opioid treatment program offering walk-in service with methadone and buprenorphine. I have no disclosures related to the pharmaceutical industry. So the objectives today are to talk about what we can do about prior authorizations, whether to ban them, whether to limit them for Medicaid specifically, although we could think about all types of insurance. One of the problems that we face in addiction is the danger of delayed care. So what that means is that if you want to make a health behavior change, it's best if someone doesn't put you on a wait list. It's also best if you work with the person's ambivalence and don't force them. So we want to talk about especially the limitations to coverage for injectable medications and why that's important for buprenorphine. So if you look at the slide here, it shows the relative lethal doses of heroin and fentanyl. That varies depending on a person's tolerance. There's a list of bill components that I sent to Brian, your policy analyst, and you can take a look at that document if you like. There are a lot of states that have put forth passed bills to limit prior auths, and this is our current board of directors, including our president, Kate Marshall. States are shown in this graphic here that have limited prior auths, including Oregon through an executive order in 2019. And there were some limitations to that reduced its efficacy. So addiction is a treatable brain disease. We often think of it as a social problem or moral issue. But treatment is just as effective for addiction as for other chronic conditions like diabetes and heart disease. So one of the issues that we come across that when we talk about things like people using drugs in the street or whether to push them to go get treated is that only about 0.5% of Americans in a given year in 2020 pursued treatment. And it often, 2020 was kind of unusual, but often the percent of people who think they need help is actually pretty low over time, which makes it pretty confounding to people in policy and also makes it so that we need special training about how to engage people. So I definitely believe what Dr. Korthus was saying about the success of peer support, because when you show that you care about somebody, they start to care more about themselves and they open up about how they're suffering. Medical care for methadone in 2 different studies showed that in one program, about half of the patients were lost after they were put on a wait list, so nobody could find them again when there was room for them. Another study showed that only 20% who were randomized to a wait list entered a program. And it didn't really matter whether they were really motivated when they first came in. So it's pretty amazing to see the improvements that I see in my patients, but it can be really heartbreaking to tell people there's no room for them. So there are only 2 medications that help with moderate or severe opioid use disorder. Only buprenorphine is available in most locations, and we need all forms and doses of buprenorphine available immediately. This is a complicated picture, but on the 3 bars on the left show the blood levels of buprenorphine when we give someone 24 milligrams under their tongue, so that the absorption varies a lot. Also, metabolism varies depending on genetics. So if you look at the center and the right, that's what happens with blood levels when we do injectable. A lot of patients start and stay on the 300 milligram, which is to the right side. I had a patient who tried for 3 years to quit using fentanyl with buprenorphine. He didn't want methadone. He only succeeded when he got the subcutaneous injection, and he was off of fentanyl for a year last time I saw him. So the effective level of buprenorphine in the blood to suppress craving is between 2 and 3. However, that information is outdated because fentanyl is so potent, and that data came from a time when heroin was heroin and oxycodone were the main opioids that were being used by people with addiction. So another solution is that this is the sublingual dose. If you can see, the people in the orange bar and even the people in the yellow bar are in trouble, because if they need a dose or a blood level of 2 to 3 and they miss a day or 2, they can end up having cravings and returning to drug use. So if we were given the flexibility to choose the dose of the buprenorphine, we could be more effective. And again, many of these patients don't live anywhere close to a place where they can get methadone, unfortunately. So in summary, treating patients without delay.
One minute, go ahead.
So I want to go back to that last slide as to what you're saying
Sure.
as to how much dose. You're saying you, as a practitioner, are limited as to how much you can give to a person? And
Yes.
Can you flesh that out? So that, to me, seems like something we should be looking at.
Of course, I think it would be highly effective if we could address this, because the injectable medicine is more expensive, but I do think we should cover the injectable medicine, because I think my patients' lives are worth just as much as patients with other health conditions, and we pay a lot of money for their medications. The other issue is that if we're going to cover the injectable, it only makes sense to cover any dose of the sublingual form, because if you could treat someone with the cheaper version of the sublingual, then you could get their blood level up sometimes. They might not want the injectable. Because for injectables, patients have to come every month. A lot of patients would like to come every 3 or 6 months if they're stable. And the injections hurt even though we numb it. I use 2 numbing agents when I do that injection. So there's a great reason to do both at the same time. It's a good question.
Thank you.
Yeah. And then I know I'm out of time. Thank you for your patience.
You're good.
So waiting for healthcare for addiction is highly hazardous. So people die when they're on wait lists, which is one reason I'm so happy to work at a place that has walk-in care. And we did get a referral from the police on Friday, or on Wednesday, actually last week, of 2 people who were going to go to jail, but the police told them, it won't really help you. So you could either go to jail or you can go to the clinic. And he said, we've been talking about doing this anyway. So the other thing that we didn't really have time to get into is that there are very few medications for opioid use disorder and for addictions in general. So if you look at high blood pressure, diabetes, you might find 20 to 40 medications. We have only 2 that we can use effectively. So we need both of them covered, and we need to be able to get them to patients immediately. Even though insurance sometimes approves an injection, it might not get shipped to us until a week later, and then sometimes we can't find the patient again. So that's both a tragic loss for the patient and also a big waste of money, because we have to then dispose of that medication. So thank you so much. If you want to contact me, that's my email address. Our website is here, and I also have a spreadsheet of some comprehensive suggestions for what else the committee might consider doing in legislation. All right, and there are some references, and Vivitrol would also be helpful to cover injectable for alcohol use disorder, so there's a slide there. Thank you very much.
All right, thank you. Representative Mannix.
Thank you. I'd like you to consider sending us information on this thought. Shouldn't we be asking our medical experts to simply report the usage of medications in terms of treatment programs, rather than limiting them in advance with harsh limits, saying, no, we'll have a regular reporting program. Let us know what you're doing so we can monitor it and see if something's out of sorts, but otherwise do what you need to do.
I think that sounds excellent. I mean, certainly we want to make sure that someone doesn't get kind of confused and start giving someone sublingual buprenorphine at 75 milligrams a day, because that's probably never going to help. And also may delay them getting effective care because they're getting a version of treatment that might not help. So that's a good idea. I think also, instead of reporting, because we have a thin network of clinicians, I think the administrative burdens of reporting might be difficult for people, but a CCO could probably generate an internal report showing how many prescriptions are coming out and what doses and what frequency.
Thank you.
Yeah, thank you very much.
Thank you so much, Doctor. And I will make note that there is some extensive, you've done a extensive sort of legislation for us to take a look at, and it is up on OLIS. So thank you so much for your testimony.
You're welcome. And would you like me to stay here for Q&A at the end of this section, or should I go back?
I think you're okay. Does anybody have any other questions for the doctor?
Okay.
Thank you so much. I appreciate it. All right. Lieutenant Jamie Russell and Sergeant Marie Gaynor, you're both remote. I don't know who's going first.
Good morning. This is Lieutenant Russell, and I will go ahead and start.
Terrific. Thank you so much.
Good morning, Co-Chairs Lieber and Kropf and members of the committee. For the record, my name is Jamie Russell, and I serve as the jail commander in Lincoln County, and I am here today to testify regarding medication-assisted treatment programs in Oregon. The expansion of medication-assisted treatment across Oregon jails has been rapid. I recently conducted an informal survey encompassing 24 Oregon jails, including Lincoln County. The findings revealed that out of the 11 jails currently without a MAT program, 2 facilities are maintaining medication for adults in custody who are actively participating in the program prior to their incarceration. The remaining 9 facilities all recognize the program's significance and have plans to implement as soon as funding becomes available, with some aiming for implementation as early as January 1 of 2024. Funding sources identified in the survey include state grants, jail general fund budgets, partnerships with external entities, and funds from opioid settlements. Upon an adult's incarceration, the jail assumes the financial burden of all medical expenses, including medications, as insurance benefits are discontinued due to the federal Medicaid restrictions. This enduring challenge has prompted the Oregon State Sheriff's Association to collaborate with partner organizations nationwide, actively pursuing a federal resolution. The expenses associated with medications used in MAT programs can be considerable, posing a notable barrier for jails aiming to implement such programs. Successful MAT programs require a multi-layer approach. Medication is only one piece of the equation. Effective treatment, monitoring, and counseling are important components as well. Establishing community partners prior to implementation of a MAT program allows for a more seamless transition from facility to facility and facility to the community. As I have learned, and you will be hearing from Sergeant Gaynor, these programs work. We know there are some misunderstandings associated with MAT. For example, the perception that MAT involves substituting one drug for another exists in our profession, as well as in our communities. The more we can educate our members and our citizens, the sooner we can eliminate the stigma surrounding these programs. Thank you.
Thank you so much, Lieutenant. Sergeant. Hi, good morning. Oh, wait, we can't hear you.
Mute.
You're on mute. There you go. Try it again.
Good morning.
Excellent. Thank you so much.
Lieber and Kropf and members of the committee. For the record, my name is Marie Gaynor, and I serve as a corrections sergeant at the Lincoln County Jail, and I oversee our medically assisted treatment MAT program. I'm here today on behalf of the Lincoln County Sheriff's Office and the Oregon State Sheriff's Association. Thank you very much for the opportunity to provide testimony today. Medication-assisted treatment is the use of FDA-approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. At the jail, we partner and contract with New Life Wellness to provide our patients with counseling, behavioral therapies, and as a prescriber while they are in and out of jail. Patients are identified by their medical condition upon intake, which would be their detox status or their self-reported drug use, as well as by request. We utilize drug testing upon intake when medically indicated. When a patient requests MOUD or is identified as a good candidate for MOUD, we schedule an appointment with our provider. The provider is Randall Kelly, and he meets with patients virtually on an iPad in booking or in the jail housing unit. If the patient is accepted into the program, Randall orders labs to be completed, and our nurses in the jail draw the labs and take them to the local hospital for processing. The results are sent to Randall for review, and then Randall will prescribe a week of Suboxone films, followed by a once-a-month injectable Sublocade. We test for medication compliance using a buprenorphine test prior to the injection, and the cost associated with this process would be the 2 drug tests that I mentioned, the lab tests that we do, as well as the medication, Suboxone, and Sublocade. And then we also pay New Life Wellness for the virtual visits. New Life Wellness utilizes an OHP charging schedule, which keeps the cost very reasonable. We have signed up with MMCAP Infuse with the assistance of the medication vendor Indivior to receive a discounted price on the Sublocade through our medical vendor called Henry Schein. This provides us with approximately $300 discount on each Sublocade injection. New medications are being used and may be utilized in the future, such as Brazaxdi, I'm probably saying that wrong, which may be a cost savings or a replacement to Sublocade. Currently, our Sublocade injections cost us between $1,574 or $1,886 each month. The drug testing is very minimal. It's $6.20 and $1.25 for both tests. Our Suboxone strips, which is 1 a day for a week, is $23.73. And the lab testing is quite expensive. It costs us between $627 and $1,000. The coordination is also quite extensive with all the patients that are coming in and out of jail and making sure they're getting these services on time. I spend about approximately 8 hours a week doing that, and our medical staff also spends about 2 hours a week doing the injection and the lab testing and counseling of the patients. Thank you for the opportunity to provide this testimony, and I'd be happy to answer any questions.
Thank you so much, Sergeant. Any questions? All right, thank you again. I really appreciate your testimony. I'm gonna call up Dr. Brian Dawson from Ideal Option. Hello.
Hello.
Hi. Thank you so much.
Can you hear me?
We can.
Oh. All right. Do you guys have my slide presentation? Oh, there it is. Perfect. Well, thank you, co-chairs Lieber and Kropf, members of the committee. My name is Dr. Brian Dawson, and I'm a physician who is board certified in addiction medicine as well as emergency medicine, and I currently serve as the chief medical officer at Ideal Option. I only have 4 slides today, so this should go pretty quick. Plenty of time for questions. Again, I will give a brief overview of Ideal Option, an outpatient addiction treatment clinic. We'll discuss a little bit about medication-assisted treatment, which you've heard about, otherwise known as medication for addiction treatment. We'll talk about how we partner with criminal justice to provide MAT within jails, and then we can discuss the outcomes for patients receiving outpatient treatment. Next slide. So Ideal Option is the largest outpatient addiction treatment provider in the state of Oregon. We actually treat patients in 9 different states, primarily in the Northwest. Ideal Option began in Washington State in 2012 and has been in Oregon since around 2016, 2017. We are the only treatment provider that publishes our outcomes on our website. We make our data available to states and legislatures and payers so they can see how effective outpatient treatment can be. We use evidence-based medications. We publish our treatment protocols. You can see we have 8 different clinics currently throughout Oregon, and we are within 2 jails at this point. The graph on the right there shows the census of ideal option patients, with the colors of the bars being the stage of care that patients are in. So you can see as patients progress through treatment, from weekly visits all the way up to monthly visits, as evidenced by drug testing results. You can see that the treatment progresses and patients are able to achieve recovery to the point where they're testing negative for all addictive substances, including methamphetamines, cocaine, and opioids like fentanyl. So they're at a point where they're coming in just once a month and receiving monthly prescriptions. And we currently serve about 12,000 patients on our active census or 1,200 patients that are active census in Oregon. So next slide. We discussed a little bit about medication-assisted treatment, otherwise known as medication for addiction treatment. And you heard the differences between methadone and buprenorphine. Methadone is a full-acting opioid agonist. It's highly regulated in federal opioid treatment programs. It's high barrier. It's difficult for people to get access. You have to go in every day to get your medications. And buprenorphine really has become the mainstay of outpatient addiction treatment. It binds tightly to those opioid receptors, but it's not like methadone. It's only a partial opioid activator of those receptors. So it can decrease cravings and withdrawal symptoms in patients, but it is much safer. So it can be used in the outpatient setting. And it also blocks the effects of other opioids. So if patients were to be exposed to other opioids, having buprenorphine in your system helps prevent overdoses. And so it allows patients to recover and maintain their recovery. Next slide. So we currently are providing medication-assisted treatment in 2 county jails in Oregon, both funded through Measure 110 grant funding. In Marion County Jail, we've been there since January of this year, and we've treated currently 444 patients. Deschutes County Jail, we launched in July of 23, and we have treated up to 44 patients currently. You can see some of the data on follow-up in the outpatient community. We provide treatment in different ways depending on what the services are available within the jails currently. So in Marion County, we actually have an on-site provider that comes in 2 days a week. In Deschutes County, that provider is telemedicine based. In Marion County, we have a registered nurse that is dispensing medications on a daily basis. In Deschutes County, that money goes towards a peer outreach coordinator because we heard earlier in testimony how vital peer connection can be to making sure that patients receive the services and are able to transition into the outpatient setting. Both of those grants, our estimated budget of about $750,000 for 18 months of service. But again, it varies based on the jails and what services are already available within the jails. So some jails have their own nurses doing dosing. Some nurses require inpatient provider visits. And so we are open to whatever options best suits the jails that we partner with. And next slide. And again, as discussed earlier, we are an evidence-based treatment program. We rely heavily on drug testing to ensure that our patients are safe in the outpatient setting and taking their medications. And we use the results of the drug testing to drive treatment, both to motivate patients to stay abstinent from dangerous substances and to reward them through progression through the stages of care. And you can see, based on our published outcomes, both objective drug test-related outcomes and also subjective patient-reported outcomes. You have significant reductions of fentanyl use, methamphetamine use, and all substance use, essentially, in patients who are stable in outpatient treatment. Patients have significantly less return to drug-related arrests or incarcerations once they start treatment in the outpatient setting. And they have significantly less emergency department and hospital-related visits when they're on medications and when they're on buprenorphine. And again, I want to stress this is outpatient treatment. This doesn't require inpatient stays. It doesn't require hospital stays. patients who are effectively monitored in the outpatient setting and ensured that they're getting follow-up and appropriate medication and testing negative for substances will recover. And it will be much less expensive than any residential type of setting. And in a realistic sense, we love residential treatment, but when patients leave residential treatment, they still require ongoing treatment in an outpatient setting. And so just like in the jails, when we're providing treatment within the jails, we ensure that patients transition to one of our clinics so that they continue treatment. If they happen to be in an area where one of our clinics isn't located, we'll work with partners in the area or other treatment providers in the area. And we're willing to help out in any way we can to provide this life-saving medication and treatment for patients of Oregon. So thank you very much, and I'm available for questions if needed.
Right. Thank you. Colleagues, questions? Yes, Representative Goodwin.
Thank you, Chair. So, Doctor, how long a period typically would an individual need to be on medical assistant therapy? Is this a short-term thing, and does the funding transition with them as they move along in the continuum of recovery?
Right. So like you've heard before, addiction is essentially a chronic disease. So just like other diseases, hypertension, diabetes, the amount of treatment initially tends to be more intense. You see the patient more frequently. It takes more time, more education, more resources. But as patients become stable in their treatment, they are seen less frequently. And so stable patients at Ideal Option are seen once a month or less frequently. And that treatment can essentially be ongoing indefinitely. Most patients require several years of treatment before their neurochemistries adapt and they develop the life skills and the community resources that will allow them to sustain their recovery off of medication. So as patients have maintained treatment for several years and maintain their sobriety, return to work, return to a healthy lifestyle, have community ties that will keep them abstinent from ongoing substance use, they are able to taper off the medications in many sense. But sometimes these are lifelong medications like other lifelong chronic diseases. And if these medications allow the patients to function in society and keep them from returning to dangerous substance use, then they're definitely worth the cost. And the cost, like I said, decreases significantly once patients reach those maintenance recovery stages.
That's a good question.
And
Follow-up. Yep.
So is that a seamless process also in helping those patients with funding the medications? Or does
Yeah, the funding of the medications, we as an outpatient treatment provider, we bill insurance companies like other providers and other doctors. So the majority of the patients at Ideal Option receive their funding through state payers like Medicaid. We have about 20% of our patients are on commercial funding. But again, as patients recover, they get jobs, they often transition from Medicaid to commercial payers. And so that funding source may change over time. We always risk, patients losing their Medicaid and then not having funding and then not being able to find treatment because they've lost their insurance because they have a job. So the payment is always difficult in the outpatient setting. In jail settings we're grant funded. So those are 12 months, 18 months, 2 years, and have to be continually renewed. But in the outpatient setting, it's insurance-based, and generally that falls on the responsibility of Medicaid programs.
Thank you.
Representative Mannix.
This is a two-pronged question. First of all, for what you just talked about, the gap, shouldn't the state be in a position to say to all the providers out there that we are going to be the gap backstop, so someone who's under a medication program, regardless of the source of funds, if a gap occurs, the state will step in and fill it until the next funding source is adaptable?
Yes, no, that would be ideal, to ensure that patients aren't losing their Medicaid funding if they're in need of certain treatment like this, or there are backup programs, like you mentioned before, where patients can, receive assistance either through grant funding. In Arkansas, for example, we have a grant from the SOAR, the state opioid response grant in Arkansas that funds uninsured patients. So if there were some backup source for funding so that patients could continue treatment, stay out of jails, stay out of hospitals because they're still getting treatment, that would be helpful.
Now, that's the continuity question. The other one is the access question, and this has to do with rural Oregon. What is our experience right now with these large number of counties with low populations? How do we accommodate having a treatment facility available and a monitoring facility available? Do you have something in your program where you connect up locally? Do we supplement what's happening locally? Because there is such a need in rural Oregon for these facilities too.
No, you're exactly right. And we have experience, in Montana and Alaska and providing treatment in very remote communities. And each community is different. So allowing the ability to provide that service through telemedicine is beneficial. Sometimes it's difficult to figure out how you're going to continually monitor patients and do effective drug testing on patients who aren't coming into a physical clinic. There are some times where we partner with local organizations to have a clinic available maybe 1 or 2 days a week within the health departments or other community service organizations where we can provide telemedicine and have drug test samples collected. And, the providers don't necessarily have to live in that community or work in the community, but they can telemedicine from other clinics. So you're right, getting treatment to more rural communities is sometimes a barrier, but allowing telemedicine is usually the best option to get treatment to those communities.
Thank you.
All right. Doctor, one question. I noticed that you've got facilities that are not in jails as well. Do you see different outcomes for those who start treatment in jail versus those who start in a non-jail setting?
Right. So throughout Ideal Option, about 10 to 15% of the patients that we see in our clinics come from jails or drug courts. And their treatment option, we don't have their success divided based on the resources or the sources where we're finding them. So that's something that would be interesting to look at. I can try to get that data for you. But essentially, when patients get into treatment, we see a pretty steady recovery based on how well patients are doing throughout the organization. So we don't have specific data on whether or not patients in those settings are struggling more than others. But I can try to get that for you.
That would be terrific. Thank you so much, Doctor. All right. Thank you so much for your testimony. I understand that Tom Kilgallen, the CEO of Ideal Options, is available, but is not going to testify. Is that correct?
Gotcha.
Correct. He's available if you have any questions for him.
All right. I don't see any, so thank you so much. I appreciate your testimony. We are going to move on to the third part of our informational meeting, where we're going to talk about deflection, stabilization, and alternative programs. I note that we have about 45 minutes for this this piece of our agenda today, and I am going to call Lisa Dugard first. Terrific. Thank you so much, Lisa. And then Malika Lamont will be sort of on deck.
Actually, Senator.
No. Who's going next?
Chief Brendan Cox, who's up on the screen,
Excellent.
is first in our three-person lead panel, and then Malika, and then I'll wrap it up.
Perfect.
If that's all right with
And that is
committee.
terrific. Thank you so much. All right. Go ahead, please. Introduce yourself for the record.
Thank you, Senator. Appreciate that. Appreciate that, committee members. Good morning. My name is Brendan Cox. I'm the Director of Policing Strategies for the Lead Support Bureau. I am the former police chief for the Albany, New York Police Department. As Lisa said, I'll be speaking first. Malika Lamont will be speaking second, and Lisa will be wrapping things up for us. I retired from the Albany, New York Police Department in 2017, and in 2016, while I was chief there, we were one of the first agencies across the country to implement LEAD. Since I left and retired there in 2017, I've been working as the Director of Policing Strategies for the Lead Support Bureau. The Lead Support Bureau provides technical assistance for jurisdictions around the country that have implemented and have operated the LEAD model. The LEAD model exists in about 85 jurisdictions around the country. We're in rural, suburban, and urban settings across the country, and we work to help provide folks the structure that's needed to help support that. In Oregon, myself and several colleagues helped the folks in Multnomah County that set up that original structure there. That was the first site in Oregon that had started. And we've been in discussions there to help those folks really look at their original design, what needs to be addressed to help tighten that up to be workable and sustainable. And recently, two of my colleagues have been in some dialogue with the efforts to relaunch a similar initiative in Gresham. And we've also been in contact with the current LEAD initiative that exists in Marion County in the program there. So we're very familiar with some of the work that happens in Oregon and very excited to be involved in that. Let me back up a little bit, talk a little bit about the LEAD framework. So LEAD stands for Law Enforcement Assisted Diversion. That is what it's originally known as. And you'll also hear us talk about it as Let Everyone Advance with Dignity. Let Everyone Advance with Dignity was introduced a few years ago as we've continued to expand a lot of what we do. And Let Everyone Advance with Dignity was really expanded as the model expanded to introduce community referrals. So a really unique aspect of LEAD is that we've introduced a way to have many front doors for folks to really be referred into LEAD. And when we look at law enforcement assisted diversion, that is the traditional way of police being able to refer folks and divert people out of the criminal legal system and into long-term services. And the most traditional way is an arrest diversion, and that's when police have probable cause to make an arrest, and rather than arrest that person, they divert that person to a case manager for a long-term system of care. And every jurisdiction makes a decision on what that charge is. So one of the very unique things is that jurisdiction by jurisdiction determine what those offenses are and really refer that person in. And that the second way that police are able to do that is to refer folks who they know are at high risk of future arrest if they don't get care and support. And we call those social contact referrals, and that is giving police a second avenue to get people into those long-term care and services without having to wait until they have probable cause to make an arrest, recognizing that police come across an awful lot of folks that need access to care, who have not at that moment committed a crime but are at high risk and are often engaged in the system, but police need access to ultimately do that. And then again, with Let Everyone Advance with Dignity, really getting community members access to be able to directly refer somebody in without having the need to call police. So really a third way to be able to not only get somebody help, but also to be able to get an avenue to get that help for that individual and also reduce a call for service to where police aren't needing to intervene in things that often police don't need to. So with LEAD, no matter what front door somebody comes in, that rest of the process is the same. And I think that's important, is that it's a handoff to long-term, low-barrier care and support. And from that point on, there's a coordination that occurs amongst those partners in that response to that person and a case management plan that exists. And that we can ultimately handle a lot of other court cases differently than they've been handled normally. So that way system partners can really act differently when it comes not only to that individually, but how we handle harm and how we handle public safety. The LEAD model was built in response to that inescapable fact that people don't recover or stabilize immediately. That's just a truth. Folks don't recover immediately from that action. And many people, it's a long pathway and it's non-linear. It's not point A to point B. Many times it's point A to point J to point Z, back to point B. That's just the truth. We need long-term care coordination framework that acknowledges that and people may still be out there doing problematic things while we're working with them, and we need to continue to work with them while those things are happening. And because all partners, including police and prosecutors, have this awareness that a recovery plan is happening for each participant, they're generally able to refrain from using the standard system responses to ultimately address things because they're aware of what's happening. And that coordinated response helps police, helps prosecutors do different things, and different things help ultimately reduce a lot of the barriers that are going on. And certainly a lot of the testimony you all heard already from folks, we know barriers exist to get folks the services and the treatment and help that they need. And we know that the more we continue to put people in the system, the ultimately the worse things get for people. The LEAD framework, it appeals to police, and it appeals to police leaders and officers because we know that enforcement is not going to solve a lot of those underlying issues. Folks use drugs for many reasons. Folks have trauma, folks have unmet mental health issues, and ultimately, police come across a lot of folks that ultimately the response of putting handcuffs on somebody and putting them in jail does not ultimately address those issues. And that prosecution in many of those issues does not ultimately address the underlying issue. So LEAD is built to ensure that when police interact with people who are using drugs in a problematic way, or police are encountering people who are committing acts that are driven by unmet behavioral health issues, we can ultimately connect them to long-term care and support. It's also built to ensure that communities don't always have to call the police to address many of those issues that first responders can't always address anyways, that they can ultimately, through a well-developed framework, create an alternative response and get people direct access to a case management team, reducing the burden on emergency response system, and ultimately take care of a lot of the chronic problems and not create crises. So I'm going to go ahead and hand off to Malika Lamont. She's going to discuss the progress of how things have been made towards implementation on a statewide basis in the state of Washington. It is all yours, Malika.
Thank you. Good morning, committee members. Thank you, Brendan. I'm Malika Lamont, and I direct the LEAD Support Bureau's Washington State Technical Support Team, which provides technical assistance throughout Washington State on the implementation of the LEAD model with fidelity to its core concepts. My background is in HIV and AIDS and opioid response work from both a local, regional, and state level, both practical and policy. I am the co-founder of the Olympia Butte Clinic, which is a low-barrier buprenorphine clinic that is run out of a licensed behavioral health entity that is run by people with lived experience and peers, a clubhouse model. I also have done direct service as a syringe services program coordinator. And if that sounds fancy, I don't mean it to. I was doing direct service work in communities on back roads of Thurston County in rural areas through both mobile and fixed site work. And throughout my work, throughout my career, my North Star has always been the advancement of the principles of harm reduction, racial equity, recognizing people who have real problems get actual help for their real behavioral health issues and to address social determinants of health. I became interested in the LEAD model after some initial skepticism. A number of my mentors in the harm reduction movement were a part of developing this model. But when I saw with my own eyes its ability to build consensus around a less harmful and more effective response for people experiencing behavioral health issues and the issues related to drug use under our current prohibition-based system, and they were much more effective than anything that had ever occurred during the war on drugs. The criminal legal system has never been an effective response to behavioral health and poverty. It often exacerbates underlying issues. It is expensive. Punishment and coercion are not an appropriate response to behavioral health issues and poverty. People need support, not punishment. The LEAD model supports the SAMHSA definition of recovery, which many folks within the harm reduction movement work to change, and to recognize that recovery is a process of change which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The elements that define recovery according to SAMHSA are having a home that is stable and a safe place to live, having community relationships and social networks that provide support, friendship, love, and hope, and that purpose in having meaningful daily activities, whether that be employment, going to school and furthering your education, having opportunities to volunteer and give back in your community, caretaking for family members, and to have creative endeavors, and the independence, income, and resources to participate in society. Finally, health is overcoming or managing one's condition as they see fit and the symptoms that they are experiencing. Much like the recognition that drove the adoption of Measure 110 here in Oregon, or there in Oregon, should I say, I live in Southwest Washington, we found that most people, often including police, agree that jail and prosecution is not going to make the situation better for most people who are using drugs chaotically or experiencing the impacts of poverty to alleviate their pain and trauma. LEAD is a channel to operationalize all of that agreement and greatly reduce the likelihood that people will be unnecessarily pushed into jails and the court system, while still ensuring that there is a felt response to real issues that are occurring in the community. The model was born in Seattle in 2011, as was mentioned earlier, but has since been adopted in many communities, in red and purple as well as blue states, and rural communities as well as big cities. I was asked specifically to address why LEAD principles are often readily embraced in rural communities. I come from, my family, I have deep roots in Eastern Washington, and I have lived most of my life in areas that would be defined as rural or slightly suburban. LEAD is a practical approach. It meets all involved where they are in their cycle of behavior change. And that includes those that are on the policy coordination group, those that are doing the operational work in the street, as well as the individuals that are experiencing the issues that bring them in contact with law enforcement or that result in a referral into the LEAD framework. It's a power sharing model that encourages communities to identify problems and work together to solve them, not just point fingers. It is a path to restoration and systemic change if those working on the initiative choose to formalize their work. The collective impact that can result from the process of working together, even when we don't agree, can be transformational for individuals and communities. The response needs to be more, not less. Oregon began the work with Measure 110. Moving backwards into the regressive policies we have decades of evidence to show didn't work is frankly the definition of insanity, doing the same thing over and over and expecting something different. Our communities deserve better. Now, I'll hand this over to my colleague Lisa Dugard from the original LEAD site in Seattle to share some lessons we've learned after more than 10 years of putting these concepts into practice. Thank you.
And Lisa, I am really hoping you're going to explain to us how this works. Like, what is
Sure.
LEAD and how it actually
I wasn't going to,
works.
but I can. I
would really like
I thought you were going to tell me we're very short on time and I
Sure.
should cut it down. So I will try to do
That
all
too.
of those
Yep.
things.
That too. You're welcome.
Good morning. It's really good to be here with you. My name is Lisa Dugard. I'm co-executive director of an organization now called Purpose, Dignity, Action, PDA. We're formerly the Public Defender Association, so we maintain that acronym.
I see.
And it's the home base for the LEAD Support Bureau that provides technical support all around the country. But we were also the sort of initial project manager of the flagship LEAD program in Seattle, and I personally was that first project manager. So we are talking about something we've done, and it's complicated and difficult. So I will, I promised my daughter I would say that I am a husky, and I'm hoping that you all will overlook that just for the next
Brutal.
few minutes.
Not listening to this anymore.
It was a good game.
It was a good game.
So I really wanted to make 2 points, and I will come back to those. But to your question, Senator, LEAD is, and actually it dovetails with the first point I was going to make. The testimony I heard before we got up here to talk about LEAD is about treatment. Mm-hmm. It is about a specific response to drug use. LEAD is not exactly about drug use only. It is about crime. It's about law violations that intersect with drug use, but are not limited to the use or possession of drugs. And it's also about the underlying conditions that drive drug use. So the social determinants of health, the needs that people are trying to meet by using drugs. If we only offer a response that is about eliminating drug use, that tends to work best for people who are coming to the table with resources. And there's something left in their life. If they take away the chaotic impact of drug use, the harmful impact, there's something there to live for. The people that we work with and that LEAD was designed for, and I was a public defender, these are people I represented for many years, that's not their circumstance. If you just eliminate drugs, you have not addressed the driving circumstances that led to that and other adjacent problematic behavior and circumstances. So LEAD is about the whole situation, if you will. And that's why Brendan is saying it's about how you come in the door is the least important thing. Once you're in the door, we're talking about months and years of coordinating care and people who likely have other things that are bringing them into contact with the criminal legal system, other reasons that they are having a problematic impact on the community. And you want to get everybody who's going to intersect with that person, have a touch with that person, driving in the same direction and supporting a recovery path rather than inadvertently putting more and more obstacles in the person's path and blowing up their road right when they are on the verge of finally making some progress, which is what we do. That's normally what happens. LEAD is about ongoing coordination between police, prosecutors, case managers, and community leaders about what's going on with this person, what are the small and big goals and steps that they are taking, and this coordination may lead to prosecutors choosing to dismiss cases that are not drug possession or public use. They may be, other crimes, more serious crimes, but the victim of that crime or the community agrees, we're not going to accomplish anything by undoing the progress that this person has laboriously worked with their case manager to make. So it's come in the door through arrest diversion, social contact referral by the officer, or a community referral, but then work with a case manager for months or years and coordinate with all the other players to get to the best outcome that is possible for that person. And so if you can take away one and only one lesson from our experience in LEAD, it's that people need, and not everybody, but the people who are of most concern, who are most impactful and most impacted, need a lot more than is convenient. They need a lot more than we have, and they need a lot more than drug treatment. And I am in no way minimizing the value of MAT, of drug treatment. I am saying that the surrounding circumstances also need somebody to lead people through a resolution, and that means tackling very fragmented, partial, and stubborn systems that are not built to work for our folks. So they need a champion, and they may need that person for some time. The last point I wanted to make before transitioning to the next speaker, who is a representative of the Seattle business community, which has been just phenomenally supportive of community-based care strategies, responding to public order and public safety issues, connects to his testimony. So originally, when we started LEAD and everything else, I think that you're hearing is about how to respond to individuals. But the fact is that's not really what drives our public policy on public safety and public order. We also, especially starting in 2020, recognize that we need to have an answer for situations that just cannot be tolerated while we wait for people to wend their way through months and years of nonlinear recovery. So we stepped into that space in a variety of ways that built out from the original LEAD model, which is still there, that individual case management is the backbone architecture. But we devised an encampment resolution response called Just Care that offered people to go into non-congregate shelter, where we put intensive case management. It's like a variant of the LEAD case management model, where the person is inside in a place. We can find them 3 times a day, not 3 times a month, make a lot of progress, but also they're not on the street while we're doing commencing that nonlinear recovery progress, and then navigating the path into permanent housing. We also last year, 2022, with other partners, and almost all of this work involves many partners. I'm not going to name them all, but it would be impossible to move this work ahead without this partnership framework. Launched something called the Third Avenue Project, which is the sort of foundation of it is street-based, what we call milieu management, people on the street from 6 a.m. to 9:30 p.m., 365 days a year, in our most chaotic downtown site of public disorder, Upper Third Avenue. And so they are doing de-escalation and sort of calming. They anticipate hostility and violence, are often able to interrupt it, and are asking people to just kind of move, their activity into a location where it would be less problematic. But that would not be enough, because they are also encountering people who need a long-term recovery plan. It's not just about keeping a lid on a situation, it's about making it better one person at a time. So they are referring people into lead case management, housing navigation, and into treatment resources. So that, I give these examples not because everybody just needs to postage stamp the same solution. Solutions need to match your situation and your community, but it's more about how our, the evolution of community-based response has to take seriously the impact of the sort of aggregation of these individual behaviors on neighborhoods and on business, and come with a response. When we do that, we have not encountered any dissension about whether that is preferable to sending people to jail, sending people to court. Most people agree that it is, as long as we come. And so filling that void has been critical, and still a work in progress for us over the last couple of years.
All right, colleagues, do you have any questions real quick before we move on? I do. So the LEAD program in Seattle, is the front door always a crime? So tell me a little bit more about the front door of LEAD.
It isn't. The eligibility is that the person has to be known to engage in illegal activity related to behavioral health issues or poverty, but not necessarily known to a criminal justice player. So it could be a police officer, but it doesn't have to be a police officer. We get referrals directly from businesses, from the Downtown Seattle Association, ambassadors, from prosecutors, from public defenders, people who they have information about what the individual does without support. And so it's a crime prevention strategy, essentially. But we do still get arrest referrals from police when they have probable cause to make an arrest for a variety of offenses.
And instead of arresting them,
they don't go to jail, and they don't get referred for prosecution. They have a warm handoff to a case manager who comes within 30 minutes to that point of contact or police precinct and walks the person out the back if they agree. It's not civil commitment, it's not involuntary, but almost everyone does agree. And then they have to sign a release of information that allows information sharing, and they have to do a multi-hour psychosocial assessment that starts to understand what's really going on underneath that presenting behavior. If they do those things, that charge is never filed, and in return, that person has agreed to do this long-term care coordination.
Great, thank you so much.
You're welcome.
Can I ask a question?
Yeah, go ahead.
So the participation in the evaluation is what stops them from being prosecuted?
Yes.
And is there a requirement of continued engagement to avoid prosecution, or is it just that initial?
It is just that initial, those two steps, release of information and the assessment, because the methodology of persistent engagement works really well. The case managers are incredibly skilled doing motivational interviewing. They go out and find people. It can be participants in LEAD talk about, it's much more of a sense of eyes on, but supportive and helpful eyes on. So very rarely do people not ultimately engage. But it's not immunity. This was a one-time thing. We have often all said, if they don't go, if there's no future problem, okay. But if there is a future problem, there's always another opportunity to take whatever enforcement steps anyone thinks is appropriate. So.
Thank you.
Great, thank you. Mr. John Scholes.
Well, thank you, Senator, and thank you, committee members. My name is John Scholes. I'm the president and CEO of the Downtown Seattle Association. We represent about 2,000 property owners, companies, and organizations. Our mission is to create a healthy, vibrant downtown for all, and we've been doing that since being founded in 1958. We work to influence public policy that affects our stakeholders and the downtown neighborhood, and we also provide a range of direct services. Lisa mentioned the ambassador program, so cleaning services, safety, security, events, marketing, and promotion of downtown services that are supplemental to city government. The LEAD program, as Lisa noted, started in downtown Seattle. It was a pilot in the Belltown neighborhood, a residential, primarily residential, but also mixed-use neighborhood in the greater downtown. As an organization, we supported that pilot and have supported the expansion and continuation of LEAD since then. I've been with the association for 15 years and so intimately familiar with LEAD from day one and have seen its successes and positive impacts in the lives of individuals, but also in improving the neighborhood on behalf of our members and all those who live, work, shop, and play in our downtown. And I would say that I think it's important for the municipal and state entities that have designed and developed an apparatus and systems around public safety to have this type of tool and intervention because it's important for us collectively. And we've seen this certainly as we've worked to recover from this pandemic in downtown Seattle. It's important for us as a community to be able to distinguish between those that are hurting outside and need help, need intervention, need services, need housing, need case management, and those that are outside on our streets hurting others. And there's a different set of interventions and accountability that should be met out in those circumstances. And LEAD has provided a set of tools that didn't exist prior to 2011 that have met the interests of our stakeholders, law enforcement in our community, and the public at large. And we certainly saw very positive impacts and resolutions during the pandemic in downtown Seattle when we had a significant number of tent encampments in our downtown, 150 or so locations of tents in January of 2021. Today, there's about 12 or 15. And LEAD-like interventions and services and engagement with individuals that were living in those tent encampments in public areas and spaces in our downtown was hugely beneficial and impactful to moving people inside into hotel rooms, connected to case management and other services, eventually into permanent housing. Those individuals did not all have to be booked into the King County Jail. Certain of them, of those individuals, were because of their violent behavior in these encampments, but a majority were connected to services. So we've seen the positive results in downtown. The program has since been expanded to other areas within the city and within the county. And again, believe that these types of tools and interventions are very important within the broader municipal and state-funded system and set of programs and policies designed to keep our community safe. So thanks for the opportunity to share our experience and perspective as you consider the road ahead in Oregon.
Great. Thank you so much. I appreciate it. Thank you so much for your testimony, for coming down here. We're going to move on. We've got two people who are going to be with us from Connections Health Solutions, Dr. Margie Balfour and Morgan Matthews. I don't know who's going to go first.
Hi, Senator Lieber. We're both going to go together. Excellent. I'll do an intro, brief intro to Dr. Balfour, then she'll go through our slide deck. So just quickly about Connections Health Solutions. First of all, thank you so much for having us on this call. We are very earnest about helping communities across the nation improve their crisis continuum of care. So we always love having an opportunity like this to discuss what we do, discuss what works, what doesn't work, and have that kind of thoughtful discussion.
Great.
So we as Connections Health Solutions are the original.
Just introduce yourself for the record, real quick, both just for the record. Thank you.
I'm Morgan Matthews. I'm Vice President of Partnerships. I'm joined by Dr. Balfour. She's our Chief of Clinical Quality and Innovation.
Great. Thank you.
You're most welcome. So as I was mentioning, we are the originators of the 23-hour observation model of crisis. Today, we operate two of the most studied crisis response centers in the nation, one in Phoenix and one in Tucson, and serve around 30,000 individuals annually. We also are growing our footprint across the nation. We're opening up a full-scale crisis center actually just outside Seattle in Kirkland, Washington, mid-2024, as well as a few programs in Virginia. And so we've seen now how, as you transition the model across the country, the rubs that come with regulations, code, and how we can help evolve in that arena. So without further ado, I'll kick it over to Dr. Balfour. As I mentioned, she's our Chief of Clinical Quality Innovation. I'll brag on her a little bit because she's a very humble person, but she's also a co-chair for the group for the advancement of psychiatry. She was also tapped recently to join SAMHSA's inaugural 988 Crisis System TA Advisory Committee, and part of that scope of work will be updating the crisis guidelines. So she has a big presence not only within our company and giving all of her knowledge and oversight, but also nationwide. Dr. Balfour?
So yes, thanks for having me, and you can go to the next slide.
Name.
So like Morgan said, I'm a psychiatrist. I work a lot in crisis systems. And the problem that we're trying to solve is that one of the biggest disparities today in healthcare is how mental health and substance use emergencies are addressed. So if you call 911 and say you're having chest pain, you get an ambulance full of trained people that are trained to take care of what you need. They take you somewhere where there are trained people standing by who can take care of what you need, admit you to the hospital upstairs if that's what you need. Insurance pays for all of this. It's just an expectation. But on the other side, if you're suicidal, oftentimes the default response is law enforcement and all the sequelae that come with that. Mental health emergencies account for a quarter of officer-involved shooting deaths. It's even more pronounced for people of color. People with mental health and substance use issues are way overrepresented in our jails and prisons. And if they do make it to an emergency room, most emergency rooms actually don't have any psychiatric care, and people just wait for hours, sometimes days, to be sent somewhere else. So SAMHSA has a vision. The good news is there's a plan to start to improve this. So SAMHSA, which is the Substance Abuse Mental Health Services Administration, which provides money to the states for mental health substance use services, they've laid out a vision where everyone has someone to contact, which is the new 988 line, which has gone live and is continuing to grow and strengthen. Someone to respond, which is mobile crisis, and then a safe place to help, which is facilities. And a big part of this model, too, isn't just to serve as an alternative, but it's really fortunate that we followed the diversion and the lead conversation, but it's also to be easy for law enforcement to access this system so that they can do those diversions. Next slide. And so as far as what that looks like, the Arizona model has been looked at as an example because, I can talk about this for hours and I won't, but for, history and just the way it's developed, there's reasons why, but over the last 30 years, Arizona has really developed a robust and pretty comprehensive crisis system that's being, not to replicate exactly, but for many of the principles to inform what's being built now nationally. And a big key feature of this, it is a system. It's not just a single program, and they work together towards common goals, being getting people the care they need in the least restrictive setting, which also tends to be the least costly because, what I want as a clinician is my patients to be not in jails, not in ERs, and not locked up in hospitals if they don't need to be. And if you're paying for things, you want those same things. And so whether you're talking about social justice or good clinical care or responsible stewardship of taxpayer funds, all the incentives are aligned to build a system like this. And so this is a schematic that it's in several crisis reports that you may have seen. It actually has data. This is real data from Southern Arizona where we are. And in this system, you can think of the services aligned along this continuum of that least restrictive care.
Whoever joined us, could you please silence yourself? Thank you.
There we go.
Go ahead,
And so
Doctor.
the least restrictive, most community-based thing would be to pick up the phone and call someone, or now with 988, you can actually text or chat. And so that's where our crisis lines and 988 comes in. So for example, in our county, Pima County in Southern Arizona, the crisis line gets about 6,000 calls a month, and then they are able to resolve about 80% of those on the phone, and they do that via telephonic counseling, helping people make safety plans, but also because our system is coordinated, the crisis line has access to software to be able to make people appointments either for the next day or two in a clinic, which can help people resolve their crisis. Then for those that need a higher level of intervention, there's mobile crisis teams. And these are clinician-only teams, so not law enforcement based teams, but purely clinical teams, which Oregon is already a leader in this with the CAHOOTS model, which is, I believe, a clinician and a nurse or an EMT. A lot of ours are 2 clinicians or a clinician and a peer. You're seeing that more and more. And these teams, I think there's like 16 of them for Pima County, and they can respond 24/7. If they do a face-to-face intervention out in the field, they resolve about 70% of those. And the mobile crisis line dispatches them, so it's all done centrally. They've got a map with the blinky dots like Uber, and they can make sure that those are being dispatched to the quickest response. And then for those that need an even higher level of care, we have our crisis facilities, which I want to talk about a little bit in more detail. But these are places where either mobile teams can bring people can walk in themselves, law enforcement can bring people, so anyone can come and get their crisis needs met either via urgent care, which is kind of more clinic-based, staying overnight in like a 23-hour observation kind of setting, or even staying a few days longer if they need to. And then most people, after going through at least that first 24 hours, are able to have their crisis resolved and be connected to community-based care back in the community. And then there's other post-crisis wraparound services. For example, we have a transitions clinic in our Phoenix facility down in Tucson. We collaborate with a peer-run agency that takes people to their appointments and makes sure that they, are getting to where they need to get and getting the support they need. There's other lower acuity crisis centers like crisis residential, crisis respite that make a good step down from people coming from one of these more acute facilities, or people can access those directly as well. And then the part, around the deflection and the diversion is we need to make these services as easy as possible to identify people and make it, law enforcement is getting so much training on how to recognize mental illness and divert them to treatment. We need to make it easy for them to do the right thing. So at the crisis line, there are crisis line staff that sit in 911's call center with the city, and they are able to intercept about 1,500 calls a month and have them go completely down this clinical path and never be involved with law enforcement at all. The mobile crisis teams, they have incentives in their contracts. For example, like if I in my house need a mobile team to come to me, their contract says they have an hour to get to me, but if I'm an officer in the field trying to serve an involuntary order to pick someone up because they're suicidal in their house, they won't open the door, instead of calling the SWAT team, which is what happens in a lot of communities, they can call the mobile crisis team, and their contracts say they have like half that time to get to them. So there's incentives like that around this. But we like to call it treating law enforcement as a preferred customer almost. And then our crisis centers are really set up with this philosophy as well. So one of the most effective things is to make it easy for law enforcement to drop people off. So we get them out in about 5 minutes. We never turn them away. And so it's easier than taking someone to jail than it is to take them to the crisis center. So all of these decisions and how all of these pieces are managed, they all kind of work together and build on each other to these overall system outcome goals of reducing jail, emergency rooms, and hospital use, and instead connecting people to the care that they need. Next slide. So talking about facilities, especially now that there's such interest in crisis services, nationwide, we're undergoing this huge, unprecedented expansion in crisis services because of funding from 988, because of really truly bipartisan support, and also coming from police reform movements where, one thing that pretty much everyone agrees on is that law enforcement doesn't need to be the default first responders, but they do need a place to bring someone. So because of all these things, there's all of this activity going on in building crisis facilities. But up until now, there really hasn't been hardly any federal attention on this issue. And so every state, if they do have crisis facilities, they've kind of been left up to their own devices to figure this out, and it's flown under the federal radar. So if I say the word crisis stabilization unit to 50 different people from 50 different states, they're going to have 50 different ideas of what that means. And so one of the things we're advocating for is to start to get some common nomenclature so that we can, start to plan these systems, build these systems, and make sure that we're building facilities that meet community needs. This is kind of my attempt to kind of start to put some things in some buckets. So on the left end of the spectrum here, you've got like high acuity. If you think about the people that these facilities can treat, you've got high acuity people who are potentially danger to self, danger to others. They're acutely agitated. They could be violent. They could be intoxicated. Meth was mentioned earlier today. People with meth oftentimes fit this category, or people who may need withdrawal management. So they're high acuity people, and so the program needs to be high intensity and have almost hospital level type safety, the ability to administer medications, the 24/7 coverage of either psychiatrists or nurse practitioners, other practitioners, to be able to deliver care to those high acuity individuals, but also keep them safe. On the other end of the spectrum, you've got your more low acuity programs, and these are things like peer respites, that really don't have much in the way of medical staffing. They're often highly staffed by peers, often for people that really need a stable and welcoming place to be so that they can feel safe, so that where they're mostly concerned with social stressors that they need in order to be able to cope with what's going on in their life. And then in the middle of that, you've got this hugely widely variable group of facilities. And so I kind of tried to sort of put down there some of the names that people are currently using for these, but some of these programs, they may be able to do some medications. They may have some psychiatric and nursing support, but maybe not 24/7. They may be able to take people who are intoxicated, but not do the medically assisted treatment or not do medically supervised detox for them. And so it's really variable. And it's very important for these programs it's very important for a community to have a clear understanding of what a specific facility can and cannot do for a variety of reasons. One is because if you have a facility that is taking people beyond its capability, that can lead to some unsafe conditions. That's actually why we were brought in to take over our Tucson facility, was for that exact reason. Also, if you create a facility that can't take the higher acuity folks, but people expected it to be able to, then you'll still end up with those high acuity people. They'll still end up in jails and emergency rooms. And then your community would be like, well, why do we spend money on this crisis facility when we still have the problems we thought it was going to solve? So there really needs to be something kind of like, in emergency medicine, we all know what level 1 trauma center, level 2 trauma center, we need something like that for these mental health facilities. Next slide. And so as far as what we do at Connections is we really specialize in that high acuity group. We want those high acuity people. So whoever law enforcement brings us, we always take them. We have a policy of never turning them away. And those high acuity folks, it's not only that we'll take them, it's actually, no, we really want them, because we believe those are the population that is most in need of specialty care. If you send them to an emergency room, they're just probably going to get restrained on a gurney and wait to be sent off to a psych hospital somewhere. Versus if they're with us, we don't use security. We have an interdisciplinary team with our psychiatrists and nurses and peers and case managers and our behavioral health techs. And so we really work to try to de-escalate them, get medication started as quick as possible. We have the space, that's more conducive, to de-escalating people than a busy emergency room is. And so we want those people, and especially involuntary. That's a population that gets left out a lot. I think well-meaning. Sometimes you'll get groups that are like, okay, we're going to build some crisis services, but it's just for voluntary people. And I'm like, well, where do the involuntary people go? And it's like, well, they still need to go to the ER. And it's like, well, but they're the ones most in need of specialty care. So it's really important to us that we are able to take involuntary as well as voluntary patients. One thing that makes it, I mentioned the law enforcement drop-off. So one thing that, in terms of facility design, that's super important is to have a separate entrance for them so that they can get in and out as quick as possible. Like I was saying, our metric around that is 5 minutes. But also, yeah, they can get in and out. They don't have to take their guns off to walk all through the facility. We've got like a little workroom for them, a restroom for them so they can get in and out. But also the stigma for that patient. They don't have to, parade someone through the waiting room with everyone staring at them, bringing someone in. Like the other patients don't know how you got here, whether you walked in or law enforcement. We have several levels of care in one facility. So for example, our Tucson facility, we have adults on one side, youth on the other. We have both urgent care walk-in, which is one of the services that CCBHCs are now required to provide, which I know is your CCBHC state. So that's people need to walk in, get connected to care, get a med refill, people who are in and out in a couple of hours to see like a social worker and one of our psychiatrists. And then we have our 23-hour observation unit where we take people who pretty much meet same medical necessity criteria as inpatient. So these are people who are danger to self, danger to others, psychotic, agitated, intoxicated, et cetera. And our philosophy there is that, so we assume we're going to resolve the crisis, which is a sort of a subtle thing, but it's an important cognitive distinction where we don't go, oh, okay, you're really sick. We're going to put you on the list to send off to a psych hospital. We say, oh, okay, you need to be on our observation unit. And we have an interdisciplinary team. We have we can start our door-to-doctor time is one of our important metrics, so we can have them seen and start medications. So it's usually around 90 minutes to get treatment started. We have our social workers and case managers calling families, talking to clinics, trying to figure out what's going on with that person. We have peer supports that are doing one-on-one work with people, also doing groups and things like that. And our techs, behavioral health technicians who are keeping the whole milieu safe. And then at some point during that 23-hour observation, then we reassess them and see if they're on the pathway to getting better. Then we work on getting them connected to whatever community-based care, which could be residential rehab, could be outpatient services, could be group homes, et cetera, or maybe one of these step-down lower acuity crisis centers, but trying to avoid sending them off to the hospital if they don't need it. But if they do, then that's when we start looking for them a hospital bed. And so we really are trying to get them care in the community as much as possible. It's an open area rather than just individual rooms with like you would see an emergency room. That allows us to, well, one, we can keep the whole unit safe because we can see everyone. Also allows for there to be social interaction, which is helpful. And then we have private rooms for when we need to have private conversations. And also that allows us to be flexible. So if we have surges in volume, we can take that temporarily and without ever having to turn law enforcement away. Next slide. And then these are just some of our outcomes. So like I was saying, about 60 to 70% we're able to get discharged to the community. I mentioned our involuntary people. That's another one of our metrics around this concept of least restrictive care, where we try, whether the person's going to be discharged to the community or continue on to hospital-based care, we really work with them to try to engage them so that they sign into treatment voluntarily, so that it's more self-directed. We work a lot with our various partners in the community to make sure that we're doing all we can to have a good discharge plan so that they're going to make their outpatient follow-up appointments after they're discharged with us. And so, so we're over 90% up in with our program that we've been doing up in Phoenix. We look at, do people come back within that 72-hour period post-discharge is really critical. And so we see very few people coming back for that. And then our law enforcement drop-off time, I mentioned that. And then substance use. I'm so glad that there was so much substance use stuff going on earlier because it really, you just need to expect that this population has both. If you look at like in Tucson, we pulled some data and showed that 15% of people come in saying their primary reason is I'm here for a substance use issue. But if you look at diagnosis and toxicology screens, it's up to upwards of 2/3 have a substance use issue. And so we treat both and just expect that, most people are going to need treatment for both. And that can include, we can do medically supervised detox, or medically managed detox. We can start Suboxone, so we can, do the full range of that. And I think that is it. Next slide. Oh, no, I have a couple. And so just Morgan mentioned, I was part of the group that wrote this roadmap to the ideal crisis system report that was put out by the National Council. And we did a follow-up companion report on metrics. The links are there. And we really spent, and so there, it's like a 200-page report, so there's tons of details on crisis services. It's complementary to the SAMHSA guidelines, but those are going to be updated as well. And we really wanted to make the point that, like I was saying, it's crisis systems are a system, and it's an essential community service. Like, we should expect the same level of consistency and care for mental health emergencies as we do for when people need police or fire, EMS. And then it's more than just a single program. And so we purposely did not start with talking about the services. We started with the base of that triangle, which is the accountability and the financing and the governance mechanisms. And so Oregon already has in place, you're kind of primed to be able to have a really well coordinated systems, because like Arizona's, for example, is built on the backbone of its Medicaid system. We were the first state to have a statewide managed care waiver. And, with your CCOs, you're very much primed to be able to coordinate all the different pieces through contracting through Medicaid. But then also you're a CCBHC state, which brings in even more ability to bring funding sources from other areas for things that aren't, all maybe not be currently billable. And so you're really primed for that. But those are two reports that, could be for some background. And then last slide. And we just, that's our contact info. And just as we've been starting to build crisis centers in other communities, we've been running into, like there's all these little things around, can you even license it? Can it get paid for? Does like some regulation need to be interpreted differently so that you can, administer medications? There's all kinds of things. And we're happy to help with, help work through some of those. The civil commitment statute, sometimes people think it needs to be a statute change, but if you actually read it, it's just an interpretation difference. But all these different types of things, and also, how is it paid for? And some other states are starting to finally start to look at private insurance too, because a lot of people who come through, like it's Medicaid and other public funds that subsidize privately insured people whose insurance doesn't pay for these things. So any help that you need with that, we are happy to provide. And Morgan is the one who's been in the weeds on a lot of that stuff.
All right, thank you so much, Doctor. I'm going to entertain some short questions, okay?
Yep.
And then we're going to have to move on. All right, Representative
Thank you,
Notes.
Co-Chair. Dr. Balfour and Morgan Matthews, thank you for your presentation. Do you have readily available housing with wraparound services that is sort of dedicated to you? Because I feel like this is something we could set up or contemplate in our state or in my county. I'm in Portland. But that is our biggest challenge. We don't really have a place for these folks. Most of these people are struggling with a proper place to live, in addition to whatever thing they present with.
Yeah, when everybody asks me, like, well, what would you improve in your system? My first answer is housing, and then my second answer is housing, and then my third answer is housing. So, I mean, it's like the basic
It's
need.
my fourth and fifth, too, so there you go.
So, we work with whatever, in every community that we go into, we kind of do like an environmental scan of what is available and work with what we've got.
Okay.
There are, we've developed good relationships with certain shelters where, they'll hold us beds and things like that, or we can, difficult person, we can call in a favor. But, but yeah, any special programs around housing, we would love to collaborate. At about 20%, which is an underestimate, I think, but about 20% of who we see are probably homeless.
Okay.
And yeah.
Anything else?
No.
All right.
Thank you. That answered it.
Thank you so much for being here. You've got a wealth of information in that 200-page report. I've started it, but I haven't quite got all the way through it. So, but I appreciate that you, I appreciate the information in there, and I would encourage, can you upload that to OLIS, that report? Both of those reports, actually. So thank you so much. I appreciate you being here. We have one more person that needs to testify, and that's Dave. How do you pronounce your last name, Dave? Dorsher?
Yeah.
Dave Dorsher? He was on here. Mr. Dorscher?
Yes.
Hi there.
Can you hear me?
Yeah, I can. We have I'm going to ask you to keep it to about 5 minutes if you can. I really appreciate you being here and waiting, but we are running way behind. So please go ahead. Introduce yourself for the record.
Yeah, Senator, thank you, and thank you, committee members, for having me here. My name is Dave DeRocher. I'm the executive director with the Other Side Academy here in Salt Lake City. The Other Side Academy is a 30-month residential program for the most lost among us. Our average student's been arrested 25.6 times. That puts into context a little bit about the demographic of our student. But I want to ask a question of everybody really quick. Is the problem in our communities getting better or worse?
All right. Well, we're probably not going to answer you, but go ahead.
Up in our communities, in my opinion, I think everywhere I go and speak says the problem is getting worse, and it's because we're responding to it wrong. I've been listening now for the past 2.5 hours, but never has anybody said anything about personal responsibility or taking responsibility for our own actions. I was a drug addict, hardcore drug addict, started with pot, alcohol, went to cocaine all the way through high school. How I made it is a mystery to me. Turned to meth, then to heroin, did a 2-year prison term, a 5-year prison term, a 6-year prison term, and a 10-year prison term. And I'm here to tell you that jails and prisons literally saved my life. Every second, every minute, every day, every week, every month, every year I did, I'm grateful for. It's where I needed to be at that time in my life. But today I know how to hug the cactus and take responsibility for my actions. I don't have a disease. I was making poor choices in my life that landed me on the streets and in jails and prisons. What I haven't heard anybody talk about is personal responsibility. And whether it's a sickness or whether it isn't is irrelevant at this point, because if you never chose to use, and many people on this call haven't chose to use, suffer from the same traumas that I did. I chose to use, you don't. If we don't start holding people accountable to the decisions that they make in their lives, this problem is going to continue to get worse and worse. I was listening to Dr. Korthia speak earlier about the death rate of kids going up exponentially. It's going up exponentially in Oregon because we're teaching kids how to use drugs. When you legalize drugs and they walk outside or they come home and they smell pot in their house, at 13 years old, they don't have the intellectual capacity or their emotional maturity to understand. 6 months later, they're stealing the pot from their parents and they become drug addicts. And a year later, they're using a harder drug. Not so true with adults who decide to smoke pot for the first time at 40. But as long as we continue to normalize drugs in this country, we're going to continue to raise a culture of drug addicts, younger and younger. We are creating the problem that many of us then pretend like we care about solving. There's no such thing as prevention if you're also encouraging people to do it. If it's the norm on the streets, if it's the norm at home, how can you prevent something you're encouraging people to do? I believe, and with 45 years of experience living this lifestyle, and right now, just to show you, I've got 150 students living here in a 30-month program that is completely free. You can walk in off the street. We will interview you. If we accept you, you start today. That is our org chart. We don't take any money from the government. If the government knew how to solve this problem, it never would have been created to begin with. We take no money from the government. We have our own businesses that generate our revenue so that we can do what's best for the student. Because truth be told, the current treatment model, 30, 60, or 90 days, please, everybody on this call, do your research later. Find me the science that says 30, 60, or 90 days is the optimal time. It doesn't exist, but we keep funding models that work very poorly, but at least they're expensive. The longer you're in treatment, the better your odds of success. We can do what's best for the students. Whole person change takes a long time. We focus so much on just clean and sober that you could have thrown me in a jail cell in jail for a year straight in isolation. I would have been clean and sober. But if I don't work on the very things that sent me there, the fact that I'd become a liar, a cheater, a thief, a manipulator, and a criminal, if I don't work on those things, I'm going to use again. Please, I just implore everybody, if the problem in our communities is getting worse around the country, whether it be Portland, that we've completely lost that city, San Francisco, LA, Kensington, Pennsylvania, which is an open air market of drug use, kids are coming out seeing it. If we don't start addressing the problem and holding people accountable to the decisions they make and using our county jails as could you imagine, I'll leave you with this, if every county jail in our country had a detox, bona fide detox on the front end. My average student's been arrested 25.6 times. If there was a detox and they were forced to detox, whether they wanted to or not, for 30 or 60 days, and then they were offered treatment, rather than being released with a promise to appear, could you imagine the amount of help we'd be able to give people and the success rate we'd have? We keep arresting people and then releasing them, and then they're going to tell the judge.
Dr. Dush,
Yes.
yeah, Dave, thank you. I really appreciate it. You're a little bit over time. I'm going to stop you there. We really wanted to hear about the Other Side Academy, and I'm afraid you've gone a little off topic here, but I am going to direct people to your website and have them go see it on your website, and I want to thank you for your testimony today. Okay.
You're welcome.
Thank you. All right.
Yep.
Okay, we are going to move on to our invited panels. We've got a number of invited panels before we get, I'm going to level set. We're not going to get to everybody. Right? Okay. First time for public testimony, not the last time for public testimony. We are going to start with Ron Williams, Julia Pinsky, and Grant Hartley. Can you please come on up here?
If I'd been binge drinking, they would have really done, they would have cracked down.
I'm going to ask the panels keep it to about 7 minutes, the whole panel, and a couple of minutes, couple to 3 minutes each, and I don't know who's going to start here. Who's starting on this?
Happy to start.
Yep, go ahead, let's put some timers on this. Okay, welcome.
Good morning. Good morning, Co-Chair Lieber, Co-Chair Kropf, members of the committee. My name is Grant Hartley. I'm a public defender, and I am the director of the Multnomah County Office for Metropolitan Public Defenders. Many people have and likely will today testify about how addiction is a public health issue and that it should be addressed as such, and that we should not be punishing people for their addiction just as we don't punish people for their mental illness, even though either can be a driver of criminal conduct. They will remind you that that is a morally right thing to do. And all of that is absolutely true. However, it is also the practical thing to do. Measure 110 was a recognition not only that prosecuting addiction is morally wrong, but also that it is incredibly costly and utterly ineffective. Despite that, some in our community are relying on misinformation and our collective impatience to propose recriminalization of low-level possession, advocating for diversion courts as so-called solutions to this issue. Those proposals are not new. They're not novel. They are the exact same thing that we were doing in Multnomah County and elsewhere when Measure 110 passed. They're the same drug policies that have exacerbated racial disparities in our criminal system, that have created countless collateral consequences in people's lives, all while failing over and over again for decades to meaningfully address addiction in our community. That is not a practical solution, nor is it practical to add thousands of cases to a criminal legal system that is already tremendously overburdened. We don't have enough public defenders to handle the cases that are currently in our system, let alone thousands more. Appointments should be prioritized for crimes with victims, rather than victimless possession cases. What is a practical solution is increased investment in treatment and housing services, investments that are targeted and focused specifically on creating capacity for the most high-risk and high-need populations. What is practical is investing in armies of peer mentors and case managers to do meaningful outreach, rather than solely relying on law enforcement who have demonstrated a reluctance to make such referrals. So I ask you to remain focused on solutions that are based in science and data, solutions that continue to move us forward and not backward. Thank you.
Thank you so much. Go ahead.
Thank you. Chairs Lieber and Kropf, members of the committee. For the record, my name is Julia Pinsky. I'm co-founder of Max's Mission, a nonprofit based in Medford, Oregon, focused on harm reduction. We are members of Burns in 3 counties, Jackson, Josephine, and Klamath. My husband and I started Max's Mission in 2016, 3 years after our son Max died from a heroin overdose. He was 25. Max hadn't been using long, but like many addicted to using opioids, he experienced a rapid downhill escalation. We had been desperate to help him, but his entanglement with law enforcement due to his possession charges for heroin kept him trapped, stuck in a penal system that offered no help. At one point, he was in the hospital about to go into treatment when a sheriff came and arrested him. We were continually thwarted by his justice involvement, and he spiraled into desperation as he was made to feel like he was not worthy of any help by those holding him accountable for his charges. We know that a lot has changed in law enforcement since then. We work with many police departments throughout Southern Oregon and with community justice. But we feel strongly that going back to punishing people for their addiction will cost lives, not save them, as many today have outlined. It is not the decriminalization of drug possession that has caused the rise in fatal overdoses, though it seems an easy blame. The Washington Post recently reported that overdose rates throughout the country have directly correlate to the number of prescription opioids that flooded the country back in 2012. This includes Oregon also. Counties that received the most pills are the counties that are now experiencing the highest number of overdoses. The demand for opioids and the subsequent generational use that we see on a day-to-day basis, combined with the spread of fentanyl, as Morgan said earlier, from East Coast to West Coast, that we saw just as when Max died and chronicled, has been the driver of drug use and overdoses that we experience now. Our problem in Oregon has been compounded by too little, too late. There is nowhere near enough treatment or detox beds, and when we finally have low-barrier harm reduction care, peers from many organizations collaborating to get people the help they need, and many programs contributing to positive outcomes every day through Measure 110, there is talk that it is not working. So we call on you to take action to hopefully supply those treatment beds and many other programs that will support what so many other organizations are doing. Thank you.
Thank you.
Good morning, Chairs Lieber and Kropf, members of the committee. For the record, my name is Ron Williams. I'm a member and former tri-chair of the Measure 110 Oversight and Accountability Council, a member of Governor Kotek's Central City Task Force, and I serve as the Outreach Director for the Health Justice Recovery Alliance. Measure 110 has averted thousands of harmful arrests and criminal records that once saddled people with lifelong barriers to housing, education, employment, and more. The significance of this cannot be overstated. When I moved to Portland in 1984, it was supposed to be my fresh start. But my life eventually spiraled out of control because of addiction. I lost everything. Eventually, I lost my freedom. Prison only put my addiction on pause. I was never offered help. When released, I didn't have any tools, ways of processing trauma, or mechanisms to cope with triggers or cravings. Many in recovery have stories like these, and now we know how to do things better. And we must do better. No one in Oregon is happy with the state of things in our communities. Since 2020, the homeless rate in Oregon has increased 23%, far more than any other states. If you look at downtown Portland alone, 58% of people released from Hooper Detox are sent back to the street because of a lack of recovery or transitional housing. Hooper Detox turns away about 200 people per month. Proponents of criminalization would have us arrest those on the street with addiction through no fault of their own. Arresting people with addiction is cruel, it's wrong, and ineffective. That's why the Health Justice Recovery Alliance policy table has submitted a policy roadmap to expand care and create a path forward. This roadmap calls for policies to expand and improve on the public health approach to addiction, to maintain and expand current funding for culturally and linguistically specific addiction recovery services, and providers, to reduce the negative impacts of addiction on our communities, to be evidence-informed and solutions-oriented, bringing together all parties working on the front lines of the crisis, from behavioral health providers and law enforcement to policymakers, local community leaders, and first responders, and more, to effectively and efficiently invest public dollars is also included. Key elements of the proposal include standing up more mobile crisis units, more detox and treatment services, more recovery and transitional housing, more coordination with law enforcement for rapid street response, such as programs like Cahoots in Eugene, or the model that they're using for Cahoots in Eugene. These are the investments necessary for a full continuum of care so that everyone in Oregon receives treatment services when they need it, and no one faces arrest because they were turned away for help. Thank you.
Thank you very much for your testimony. I appreciate it. We're going to call up the next panel, which is Max Williams and Kevin Barton. I am going to set this for 7 minutes. I just want you to know that. And when it goes off, I just want you to try to wrap it up. So I'm trying to do that. How do I do that? How do I do that? And what by me, I mean Brian is going to do it. All right. Welcome.
Thank you. Madam Co-Chair, Chair Kropf, members of the committee, my name is Max Williams, and I appreciate the opportunity to offer testimony on behalf of the Fix and Improve Measure 110 Coalition. As you're aware, the coalition has filed an initiative petition to make changes to ballot Measure 110, but our hope is that the legislature will address this issue comprehensively in the February session. Mr. Barton will cover some of the specifics that we want to talk about today, but there are a few points I'd like to make, and I'll consolidate my testimony, the full version which has been submitted. We don't believe that Measure 110 created Oregon's addiction crisis, our mental health crisis, or the virtual rise in almost all crime categories, but we do believe that the evidence suggests that Measure 110 has exacerbated those circumstances across the state. Overdose rates are rising substantially higher than the national average, and you heard Dr. Cordius point that out, even greater so with teens and youth in this state. And while we may not be as bad as other states, the last I checked, this isn't a competition to find out who's least worst. Active drug markets are active and present in our major cities and communities. Businesses are struggling to deal with the reality that decriminalization has created, as are neighborhoods and families. I think the evidence speaks for itself about its impacts if we're willing to look at it objectively. The center piece of Measure 110 for accountability was the ticket writing process, the Class E violations for those in possession of these deadly drugs. And I think, again, objectively, we can say that this process has failed. We have currently the most recent Oregon Judicial Department report on Measure 110 confirmed that less than 1% of those who actually received citations went through the process to receive treatment, evaluation, and a referral. Less than 1%. I don't think we can call that a victory. There are practical solutions that we can achieve through reforming Measure 110, and I want to make a case for early intercept using the law enforcement process for treatment and recovery. Having ran the Department of Corrections, I can tell you that more than 70% of the population were people who were suffering from addiction, and their addiction was related to them entering the prison system. But they weren't in prison for possession of drugs. We haven't put people in prison for possession of drugs for probably more than 40 years in Oregon. But their drugs played a significant role in the commission of serious felony property crimes or person crimes that resulted in their ultimate incarceration. If we want to avoid that long-term trajectory for individuals who are wrestling with addiction, our efforts should be to intervene sooner with quicker intercepts, including the kinds of intercepts that will hold people appropriately accountable and give them options to enter into treatment and recovery, along with consequences. You heard Dr. Cordius say that, for example, compelled treatment using law enforcement tools is effective. I'd encourage you to look at the testimony that's been submitted today by Stanford professor Keith Humphreys, a former Obama White House drug policy advisor, and also that of Chris Wigg, the executive director of Emergence Addiction Services in Eugene, Oregon. all this testimony will support that, not to mention 30 years of our own experience with Oregon drug courts and the lived experiences of literally thousands of Oregonians with substance abuse challenges who have benefited from such programs today and find themselves in recovery. Currently, law enforcement lacks the necessary tools to help people in their communities using and addicted to these illegal drugs, and they're asking for those tools to be restored. And they're joined by 74% of Oregonians across all demographies, all demographics, who believe Oregon should recriminalize possession of these lethal and damaging drugs. Now, I'll just end with this comment. When I was serving in this body more than 20 years ago, we made the decision, because of the meth crisis in the late 90s and early 2000s, to put a pseudoephedrine behind the counter and require a prescription in order to purchase it. That policy resulted in a huge drop of the number of meth houses that were being polluted in Oregon, dramatically reduced the number of children and individuals exposed to those who were manufacturing the drugs. It disrupted supplies and was seen as a common sense solution to what the state was then facing as a serious problem. Those laws are still in place today. We likely have numerous other laws, particularly as it relates to youth, that are designed to keep people safe. We spend and have spent millions trying to convince youths that smoking, drinking alcohol before the age of 21, and riding a bike without a helmet are all bad ideas, and yet we've enacted laws and addressed with standards that include varying levels of accountability. But today we're sending an incredibly mixed signal. An incredibly mixed signal about what we ultimately care about and what message we want to send to youth. And unlike a cigarette, a youth's experience with fentanyl the very first time can kill you. Yet Oregon spends substantially less on prevention efforts for these lethal drugs than we do for tobacco prevention. Your own prevention witness in the very first hearing actually testified that the youth she works with are convinced that Oregon's position on decriminalization will result in more youth being addicted to these drugs. When we decriminalize these drugs for adults, we decriminalize them for youth as well. What is the message that we want to send? Finally, we have a bigger message that you're allowed to send as a legislature about the values we have as a state. We are sending messages all over that we, through this decriminalization process, have hurt us reputationally in a variety of ways. You've all read the national press. It's cutting out our access to capital. It's having significant impacts. And one of the questions that I guess I would just say is worth noting is that both the state of Washington and the city of Seattle both quickly acted to recriminalize possession of these drugs after they were shortly decriminalized. The question I would pose to all of us is, what do we think we know that the rest of the nation doesn't? These actions won't solve all of Oregon's problems. Many of them are deeply institutional and systematic, and you know that. So please, while you work to make progress on that front, don't let these challenges stop you from acting now. Don't let the perfect become the enemy of the good as we address these issues. And with that, I'll turn it over to Mr. Barton.
Thank you.
Thank you. Good morning, Co-Chairs Lieber and Co-Chair Kropf and members of the committee. Thank you for the opportunity to be here and for convening this conversation. I'd like to start by just acknowledging something that I think is true, that everyone in this room is here because we truly believe there's a problem that urgently needs to be fixed. The differences that we have, to the extent they exist, relate to how to best accomplish that fix. My name is Kevin Barton. I'm the Washington County District Attorney, and I'm here along with Mr. Williams on behalf of the Coalition to Fix and Improve Ballot Measure 110. We believe that our proposal is a proposal that provides an avenue toward accomplishing that fix. Our vision is a shared vision, and it focuses, thank you, it focuses on both individual harm and community harm. And we've heard a lot about individual harm in conversations about substance use addiction, but we don't hear a lot about community harm as well. And we believe that both are equally important. Of course, individual harm relates to things like overdose incidents, overdose deaths, the impact on the individual who is using. Community harm relates to the impact on that people around that individual, the family, the friends, the neighborhood, the community, the crime, the homelessness, the houselessness, the impact on the children and the adverse childhood experiences, or ACEs, as many of you know that phrase to relate to. Our effort has two guideposts. The first is more treatment for more people more quickly. And the second is using or recriminalizing and using the criminal justice system only to the extent minimally necessary to encourage people to engage successfully in treatment, a surgical use of the criminal justice system. I'd like to talk with you about that phrase, recriminalization, which I understand is a charged phrase. But we believe that recriminalization is a key piece of a larger picture to accomplish those goals that I mentioned. Imagine a scenario where someone is on the streets and they're using drugs, and a police officer or a non-police officer encounters that person. Our proposal provides 3 ways the criminal justice system can be used, but 3 off-ramps so that person is not left in the same situation they would have been left in pre-ballot measure 110 or in 2019. What we're proposing is something new. The first off-ramp, you've heard conversation about the LEAD program. It's called pre-booking diversion. It's an opportunity where communities that have the resources and have the community will can opt into a program where they can engage in pre-booking diversion like LEAD, where the officer or a non-police officer responder, like a Cahoots responder or a Portland Street Response responder or a mental health response team responder in Washington County, can give that person an opportunity to do something other than going to jail, other than being arrested. They can go into a treatment program right then and there. And if they do, they never see the inside of a courtroom, they never see a prosecutor like me, they never have a criminal justice record, and they engage successfully in treatment. That's off-ramp number 1 in the recriminalization process. If they choose to do that and they succeed, that's great. If they fail, or if they say, no, I don't want to do that, off-ramp number 2 is they would get criminally arrested or criminally cited, but then they would have the opportunity to engage in court diversion, just like we have for drunk driving, for DUI. And that tried and true program that we use for driving under the influence, court diversion, will be offered to people in the possession of a controlled substance scenario or in the public use scenario. And they would engage successfully, hopefully, in that. And if they do, they walk out with no criminal history. If they don't engage successfully, or if they choose not to, then off-ramp number 3 will be the traditional prosecution and probation and supervision. But if they successfully complete their probation and their supervision, then they would qualify for an automatic expungement, meaning they're never convicted of anything and they walk out without having to even ask for the expungement or to file anything. So our recriminalization proposal is very different than the way things looked pre-Measure 110 and in 2019. But it does provide that opportunity to surgically use the criminal justice system only to the extent minimally necessary to engage in that treatment to accomplish that goal of more treatment for more people more quickly. Thank you.
All right. Thank you very much. Thank you so much for your testimony. We're going to move on. We've got some remote testimony from Andy Coe, and then Gloria Sandoval will be on deck, and then Mercedes. Are you here in the room? And then Mercedes will be next. I saw you. Okay, go ahead, Mr. Coe.
Hello, everyone. Thank you, co-chairs Lieber and Kropf, and committee members. I am Andy Coe, Executive Director of Partnership for Safety and Justice. Sometimes you hear me say PSJ. We're commonly known as PSJ as well. I really regret not being able to be with you today. I came down with something and I didn't want to get you all sick. So here I am on the screen. At PSJ, we believe in our nation's true drug problem is its history of 2 very different drug policies. One for people blessed with privilege who are broadly immune from punitive drug policies, and another drug policy for Black and brown people, people deprived of essential health services, and people who lack basic human necessities, such as housing. 1 or 2 people have mentioned housing today. 3 values inform all of our work at PSJ: accountability, equity, and healing. Accountability, equity, and healing. In relation to our support for Measure 110 and ending the practice of criminalizing people suffering from addiction, equity means equality under law, both in form and in practice. Not one drug policy for the privileged and another for our most vulnerable individuals. Accountability means accountability without oppression, accountability without exploitation. And healing means healing for all people, not help for some and harm for others. What has been referred to as the war on drugs for the past half century has violated all of these values. Over time, those who support continuation of punitive drug policies have gradually sought to disassociate those policies from that label. But in our view, any claim that the war on drugs never happened in Oregon would be akin to ignoring historical impacts of slavery in life in America in the historical context of other similar policies on our country and our people. So it is the position of Partnership for Safety and Justice, in my personal opinion, that equity, accountability, and healing require a single health-centered drug policy for us all. That is the point of Measure 110, as enacted by the people. It and we are fully up to the task. Measure 10 does not need to be fixed. Measure 10 just needs to be implemented. Thanks very much, and I'll look forward to continuing this process in the future. Thanks very much.
Thank you. All right, Ms. Sandoval.
All right, thank you. Co-chairs Lieber and Kropf and members of the committee. I'm Gloria Ochoa Sandoval, the policy director at Unite Oregon. Thank you for having us here today. For those less familiar with us, we're a grassroots statewide nonprofit organization that represent and are led by Black, Indigenous, people of color, immigrants and refugees, rural communities, and people experiencing poverty. We've been working on Measure 110 since 2020 and working on decriminalization for much longer. Unite Oregon exists to address the intersectional impacts on our communities, including community safety and health equity. Ballot Measure 110 was our opportunity to support decriminalization in a sustainable way with health support for our communities. Our criminal justice system was built to criminalize Black people. The war on drugs, known as the war on public enemy #1, according to President Nixon, which was actually a war on Black and brown people, and now the new Jim Crow, which is using mass incarceration for racial control. Even if that is not our intent, this is the foundation of these systems, and therefore any form of criminalization is the oppression of Black and brown people and people living in poverty. We have been crying for help for years, and Measure 110 was only the beginning. Voters passed it in 2020. The legislature worked on implementation policy in 2021. The state worked on the creation of the program in 2022. And our communities have only had about a year to actually make it work. And it has for those that have been able to access it, but we need more funds. Recriminalizing our communities will not address the spike in drug use. Our members have gone through a pandemic, health crisis, housing crisis, and economic crisis, and criminalization does not address those harms. It makes people into criminals. In my own family, I've seen folks use drugs to escape the reality of their life. They were criminalized for it. And while incarcerated, their reality became worse. They were abused physically and sexually, which was what they were trying to escape to begin with. They were then returned to the streets with a record and the trauma that bars them from a job, that bars them from funding, that bars them from housing, that bars them from safety. Putting people behind bars is exiling our families and my uncle from our communities. Recently, he received care support, and I'm proud to say that he is now sober, something that could have never happened and did not happen while criminalized. I can also confidently say that there's a solution to drug use and addiction, and it's a full investment in the continuum of care, like overdose prevention. More so, making sure that it's truly accessible, meaning it provides interpretation and translation, culturally specific support, near a transit line, and so on. For it to work, this costs money, and it's the same money that folks are considering to invest in criminalization, which is expensive. So I leave you with the question: are we trying to help our communities heal from drug use and addiction, or do we just want them out of sight? Thank you.
Thank you. Go ahead.
Hello, co-chairs Lieber and Kropf and members of the committee. My name is Mercedes Elizalde, and I am the Director of Advocacy at Latino Network. Our program spans Senate Districts 13, 19 through 25, and House Districts 25, 37, and 42 through 50. At Latino Network, we provide diversion and prevention and reentry programs, and key to our approach is a family inclusion model, because criminalization is never limited to the person arrested. There are always broader impacts on family and community members, and our programs really seek to serve the rest of that. So when we have an opportunity to do something like decriminalize, what we're also doing is we're alleviating the pressure and the pain that happens to fall on family members and children who are also part of that family. Criminal records hinder access to the very things needed to increase the likelihood of attaining and maintaining recovery and personal stability. They limit effectiveness of all the interventions that people advocate for, including those who advocate for forced treatment, because criminalization will continue to have consequences, usually most notably about a year into somebody's recovery journey when they are trying to get a job, a promotion, when they're trying to be the leaseholder on their home. And please be sure that arrests where charges were never brought, arrests where charges were dismissed, arrests where charges were even exonerated will continue to show up on somebody's background check for an employer and housing. On the cost, as you heard earlier today, jail services, court-mandated services, and crisis services do not bill insurance. So if we continue to use those systems as trying to create access to services, we are letting off the hook in a massive way effectively the entity with the most money and the most requirement to be addressing this issue in the healthcare system, insurance. We're just taking that off the table. And we can't forget that even when we've seen our drug policy shifting over the years from felony to misdemeanor, what we saw was that the racial disparities in arrests persisted even then. So recriminalization will go back to disproportionate racial impact on Black and brown men. There is no reason to believe that it won't. This isn't to say that law enforcement can't play a role. Although our law enforcement system, again, you've heard that today, holds no source of solutions for what we're trying to address. Many advocates will tell you stories of an officer or a judge who saw them as a person with full potential and who acted as a connector to those services. And there is no reason why today officers couldn't be carrying that information with them as well, knowing the providers in their community and offering that when they're engaging in a ticketing engagement. Naturally, most nonprofits, we don't run commercials. We do work off word of mouth. We'd very much appreciate those who are out there in the community sharing our stories of what we can offer, getting to know us as partners in their community. To say that, keeping in mind that decriminalization, the effects of it were really about avoiding the long-term collateral consequences that maintain people in crisis. So giving up or quitting on criminalization won't necessarily change the health outcomes because it misses the point by putting energy back into criminalization and not where it needs to be, which is improving our healthcare system. We need a substance agnostic or polysubstance affected responses, removing those prior authorizations, regional investment plans, and scaling up prevention and capacity. We need collaboration along our elected officials and around our government bodies so that different parts of the work don't continue to be owned by different departments and different agencies with different outcomes. And we need to grow the capacity large enough to hold vacancy in shelter, vacancy in affordable housing, residential treatment, and recovery so that it is available when people need it. And lastly, I want to say that accountability and punishment are not synonyms. A peer support specialist, a community of love, high expectations will always offer more accountability for a long term than the boogeyman of jail time. Thank you for the opportunity today, and please continue to invest your time in healthcare solutions.
Right. Thank you so much for your testimony. All right. We've got next people are Derek Sangston, Tiffany Edwards, and Corey, is it Fallardu? Close? Not really close? Okay.
We had a switch, a substitution.
Oh. Oh, that's okay. I already mispronounced her name, so she's not here.
Thank you.
Okay.
I'll start.
Go ahead.
Co-chairs Lieber and Kropf, members of the committee. For the record, I'm Derek Sangston, Policy Director and Counsel for Oregon Business and Industry. Thank you for the opportunity to comment on Oregon's ongoing public safety and behavioral health crisis. Businesses across Oregon, in communities small and large, encounter the symptoms of this crisis daily. Examples include open use and sale of drugs, retail theft and property crime, and constant threats to the safety of our customers and workers. As a result, Oregon's businesses have had to bear added costs to clean up and repair damage to their buildings and storefronts, invest in private security, and train their employees to keep themselves and our customers safe. Businesses have also endured lost revenue due to stolen or damaged products and reduced foot traffic. One member of OBI reported losing $9 million to theft in 2022 alone, which was an increase of 21% from only 2 years earlier. Another OBI member suffered over 9,000 known thefts, 85% of which were evaded. Both companies report experiencing multiple crimes against people per month. While that data is representative of what a larger corporation faces in Oregon, OBI's small business members report they experience relatively similar impacts. In response, businesses throughout Oregon have made the difficult decision to permanently close, relocate offices away from urban cores, and continue work-from-home policies to keep their employees safe. Until our workers feel safe, asking them to work in Oregon's urban centers will be equally difficult. Though ballot measure 110 was not the sole cause of this crisis, OBI urges this committee to recognize that it has exacerbated it. In September, OBI convened a listening session attended by chambers of commerce from every corner of the state. We appreciated that many of you were able to attend. Throughout that meeting, there were calls to invest in law enforcement, change and enforce drug laws, help offset the extraordinary costs to business, and expand addiction services. While a successful response will require this committee to determine how each of those calls can complement the others for the greatest results, OBI urges you to take bold action to give law enforcement and local governments the tools they need to combat this crisis during the 2024 session. We simply can't wait till 2025 or beyond. Thank you.
Thank you. Go ahead and just introduce yourself.
Thank you. For the record, my name is Lena Prine. I'm the Director of Business Advocacy for the Salem Area Chamber of Commerce, representing businesses here in the capital city. Thank you for the opportunity to provide comment on addiction and public safety in our community. In October of this year, we conducted a survey of our business members, and we wish to share the following data as you consider responses to the impact that Measure 110 has had on communities throughout Oregon. 60% of our respondents experienced open market drug use near their businesses. 100% have experienced one or more of the following in the last 24 months: trespassing, property damage and vandalism, theft, loss of sales revenue, and an increase in garbage and trash. 75% have had monetary damage to their property ranging up to $10,000 per incident, and 74% believe that Measure 110 has decreased the quality of life here in Salem. The Salem Chamber represents businesses large and small throughout our region, and as the capital city, we feel our members have a unique perspective on this conversation. We strive to help local businesses not only come to Salem, but to stay. Prioritizing investments in public safety, providing the right tools for law enforcement, and ensuring communities are able to thrive must be a priority for lawmakers in this discussion. Our members have shared their experiences with crime, direct threats, an unpredictable environment in which to operate that includes vandalism, theft, and immediate danger to themselves, their families, and their employees due to current practices. It's time to change to help our economy and our state grow. We ask for your support and partnership in making Salem and other communities around the state a place where people and businesses want to grow and remain. Thank you.
Thank you. Go ahead.
Thank you, co-chairs Lieber and Kropf, and members of the committee. My name is Tiffany Edwards. I'm the Vice President of Policy and Community Development for the Eugene Area Chamber of Commerce. We have been extremely engaged in the issue of housing and homelessness, and included in that, the impacts of Measure 110. So much so that we now have a dedicated staff person leading the Eugene Chamber's homelessness initiative. This work goes back several years in response to what we're seeing on the streets and much of what you've heard from the previous, my colleagues. The safety and well-being of our employees and customers and the overall wellness of our community has been is in a dire situation. The Chamber found itself uniquely positioned to convene passionate individuals in both the public and private sectors who have come together in response to a crisis and actually bringing hope, action, and resources. We are a couple of years into this work. The work of this committee is you all, is incorporated into our process and our advocacy strategy. Our action plan includes housing production strategies, collaboration around securing adequate resources for shelter, public safety and services, a public education campaign, and a workforce program for shelter residents, which is already launched. The Measure 110 conversation is a component of our work, but our strategies are designed to address multiple fronts. Eugene has had a very visible issue with our unhoused. We have the highest per capita homelessness rate in the country. But what we've seen, likely as a direct result of Measure 110, is the open drug use in public spaces, places like our parks, transit centers, public libraries, making these areas feel very unsafe. We've seen increased theft, property and person crimes, and other crimes related to behaviors of individuals suffering from addiction. Those individuals who are desperate to acquire resources to support their addiction. Our law enforcement tells us they no longer have the tools they need to keep our community safe. We've been following the work of this committee, and you can expect that the Eugene Chamber will certainly continue to be engaged and data-driven with our advocacy. And we encourage you to take action in providing the tools, the funding, the resources, and the accountability needed to support the entire system and enable us to all turn the corner and start to work our way out of this crisis and restore some hope to Oregonians. Thank you.
Thank you so much for your testimony. I appreciate it. We're going to move on to the next group. It's Mayor Lieber.
Hi, I'm online.
Oh, perfect. Okay. And then Jen Lewis Goff. I don't know if you're remote or in here. All right. Go ahead, Mayor.
Thank you so much. It's still morning, so good morning, Chair Jokers, Lieber, Kropf, and members of the committee. I'm Heidi Lube, the mayor of Tigard, and I really want to thank you for the opportunity to speak with you today. As you know, we're in the middle of a crisis of our communities, and I want to share the impact it's had. Tigard is a community in the Portland region along the I-5 corridor. We have about 56,000 community members, and we've worked hard to be a welcoming, safe community to live, work, and play. You may know us for our Summer Balloon Festival or from our hard work on land use and housing production. But we've experienced an impact from the Oregon-wide addiction and community livability crisis. I want to begin by centering my testimony today with the understanding that it's the goal to provide the treatment and care needed for every member of our communities across the state to be healthy and thriving. The results of Measure 110 mean that we're no longer able to stop and prevent public drug use. In our downtown area, we've had to close public restrooms for extended periods of time. This is due to the unsafe nature our community members using in our restrooms. Sometimes they lock themselves in to use and they pass out or overdose. It's resulted in situations where we've had to break into the restrooms for welfare checks, which then also requires repair, as well as the unsafe space that's left behind even when we don't have to break in. The reality is it's not safe for any of us to use these restrooms when there's paraphernalia left behind, not to mention the inability to guarantee safe, clean air inside. When these restrooms close, our community has nowhere else to use the bathroom, and it's resulted in many people using business parking lots, back areas, and sidewalks as restrooms. We have the videos to back that up. Our businesses are bearing a large share of the crisis too. Not only are they being asked to clean up human feces around their business, but they're losing employees because of what they're being asked to deal with. We've had employees who've had to manage crisis situations where they have been threatened, harassed, and left in tears after the exchange. It's not just a matter of helping those in crisis, but also helping the community who is being traumatized by bearing the weight of it. The lack of available places to take community members is an overwhelming challenge for us. In Tigard, we have a community member who's in crisis and regularly asks for help. She's literally reaching out, asking for help, and there's nowhere appropriate to take her in those moments. It's critical to ensure that we have stabilization, detox, and treatment facilities for all ages and needs throughout Oregon, and the stable funding sources to ensure long-term success. While it's an Oregon-wide crisis, the impact is really felt where people live, in cities and on our streets. We must have the ability to protect all residents and community members, and our partners must have what they need to support our efforts. There are 11 comprehensive recommendations developed by a coalition of chiefs, sheriffs, DAs, and the LOC that help us do that. I want to be clear, we do not support incarceration as the solution to our addiction crisis. We are not going to arrest our way out of this, and it's not the appropriate solution to help solve this crisis. Yes, the recommendations do allow someone suffering from addiction to enter the criminal justice system, but those entrances also come with exits and alternatives that weren't there before. So creating a misdemeanor offense for possession will allow police to seize narcotics and create a pathway for constructive supervision and treatment services through community corrections in the event a person is charged. The coalition plan calls for multiple diversion opportunities and expansion of specialty courts to help that person recover. We aren't going to tell someone you only get one chance. Experience tells us many people may need multiple opportunities to get better, and we should support that. The coalition plan also calls for the rapid expansion of detoxification facilities and 72-hour holds. The League views this as a means to divert individuals from jails to a place where they can start or reignite the recovery process. It's the position of the League of Oregon Cities that a criminal charge should not be the first option for a police officer encountering a drug-impacted individual. A treatment environment, such as a detox stabilization facility, should be the first choice. You know, cities want to be part of the solution, and we have 2 cities who are operating or plan to begin operation with specialty courts. The LOC would like to work with the legislators and partners to expand municipal specialty courts to allow us to tailor our response to local needs. That will require statutory changes and funding. We believe cities can foster innovation and should have the opportunity to chart our own path. You know, cities are at the front line of the crisis, and we want to work with you in partnership. We're asking for the tools to be able to do that. Please look at the recommendations from the League and our public safety partners. We need these changes to put Oregon on a better path to being healthier and safer for all of our community members. And now is the time to make those changes. Thank you.
Thank you. All right. Ms. Lewis-Goff.
Good morning, co-chairs, members of the committee. For the record, my name is Jen Lewis-Goff. I'm Legislative Affairs Manager at the Association of Oregon Counties, AOC. Thank you for the opportunity to testify this morning. AOC is a nonpartisan organization representing Oregon counties governments. Each of Oregon's 36 counties are unique. We like to say if you've seen one county, you've seen one county. But all counties and county elected officials are the state's partners in government. Counties implement programs created by the state and provide essential public services to every Oregonian. Many of the policy proposals related to Measure 110 that you will consider in the coming session have direct impacts to these core public services and budgets which are managed at the county level. As you know, counties are the local public health authority. Counties are the local mental health authority. Counties provide community correction services. Counties employ the staff and offices of sheriffs and district attorneys, paying for 76% of DA costs across the state. Because of the direct impact of Measure 110 to counties, overwhelmingly we hear from our membership across the state the need and desire to reform some aspects of Measure 110. Our members want more people to engage in the treatment they need to thrive. Our members want their communities to be healthy and safe. Indeed, some county boards and county courts, in response to the crises in their communities, have already acted independently on resolutions related to Measure 110. AOC is not involved in those community-based efforts, but supports each county acting on policies as needed for their communities. From an association perspective, we are focused on elevating the county voice in Measure 110 reform, supporting policy modifications that do three things: prioritize engagement in substance abuse treatment, provide sufficient funding for county services, and strengthen tools the criminal justice system can use to fight illegal drug sales and use. We further support Measure 110 reforms to create a sustainable, complete continuum of substance use disorder prevention, treatment, and recovery capacity that matches community need and is subject to the statutory planning and oversight of local mental health authorities. Counties are already operating within tight budget margins and diminishing levers to raise local revenue. Each county has different infrastructure and programmatic needs, some very substantial needs. We encourage you to consider solutions and resources that meet communities where they are and enable each county to be successful. Different counties will find themselves at different milestones on the journey of implementing enforcement, recovery programs, and so on. One-time funding cannot be the entire solution. We need to build out systematic funding solutions to ensure our counties can continue to deliver critical services to our communities. We must work together to ensure changes that come through the legislative session are properly funded. For example, if policy changes increase community corrections populations, we must appropriately fund those services. There's already an existing unmet need of $16 million in community corrections funding this biennium, and we don't want to further compound the problem. AOC will be working with our members to evaluate policy proposals as they are shared. We will continue to weigh in on those policies which have direct impact to counties. Again, I'd like to convey AOC's appreciation for being invited at this table. This is an important topic to our membership across the state, and we are eager to work with you to implement solutions that are meaningful for all of our communities. AOC stands ready to partner with this committee and legislative leadership to ensure legislative solutions strengthen and sustain the local public services infrastructure on which we all rely. Thank you.
Thank you very much for your testimony. All right, we're going to move on to the last of our panels, and then we will move into public testimony as it was signed up. So I've got Shannon Jones, Jose Luis Garcia. I think you're remote, and then Julia Mines. Hi, Shannon. You can go ahead. Thank you.
Hello, Chairs Lieber and Kropf, members of the committee. For the record, I am Shannon Jones Isidore, and I'm a Portland native and resident. I'm also the CEO and founder of Oregon Change Clinic, the only culturally specific substance use disorder and mental health treatment center specializing in working with African Americans and the United States veterans in Portland. Forced treatment doesn't work. Treatments work best when people are ready for it, And we have a moral and public health imperative to make treatment available for everyone who needs it. It doesn't make sense to create new laws and mandates that will be ineffective and put people at risk. If forced into treatment, people can grit their teeth long enough to get through it, to check the boxes necessary to get released. But if they weren't ready for it, then it becomes a dangerous situation. People go back on the streets, they continue to use, their tolerance is now lower, and we increase the chances of overdose. A better solution is to dramatically increase our street services and outreach, where there can be adequate care available for everyone. Slapping handcuffs on people who aren't ready, that are already in trauma, hauling them away, as some people are proposing, would be cruel, and I don't know that we should force our police to be in that position. With Measure 110 funding, us at Oregon Change Clinic, we've been able to substantially expand services. We've remodeled a dilapidated motel in Portland, providing 6 months of intensive outpatient treatment for those in our housing. Our certified recovery mentors run that housing. As people graduate, they tend to have employment. They've learned skills. They are then helped into long-term housing. And as a United States Marine, accountability is important. We hold people accountable. People that are in our treatment and in our housing are accountable for where they are. They must attend treatment regularly. We do urinalysis. They must account for where they are if they're not at our housing or at the clinic. We do curfews, room inspections, and then I also show up to do military level inspections. I would say that with expanded capacity, we could treat more people, provide more housing, extend our services, and to help people to stabilize that are in crisis. I also want to make a clarification on one of the previous testimonies. Oregon Health Authority, OHA, reported 134% increase in people seeking SUD treatment. Thousands of people are getting help. Measure 110 citations need to be improved. OHA data is the right data for us to look at. We cannot go back to failed policies of the war on drugs. Arrest records helps to, it impacts people that are looking for employment. It impacts their housing. It perpetuates a cycle of poverty. And unfortunately, people of color, Black people, are arrested at 4 times higher the rate than white people. The reliance of punishment and imprisonment hasn't worked for many of us. We need to invest in proven solutions like mental health and addiction services. We cannot arrest our way out of this crisis. Thank you.
Thank you. Go ahead, since you're here, and we'll go next then to Jose Luis Garcia. We'll go with you, Julia.
Absolutely. Chairman Lieber and Kropf, members of the committee, for the record, my name is Julia Mines. I'm the Executive Director of the Miracles Club. Our organization is part of the Indigeneity Measure 110 Behavioral Health Network and the Oregon Black, Brown, Indigenous Advocacy Coalition, a coalition of Black, Brown, and Indigenous providers of substance use disorder mental health services. Our purpose is to build the power of people for communities most negatively impacted by the failed policies of the war on drugs. My organization, Miracles Clubs, was founded in 1993 by 3 men in recovery who sought to create a safe, sober environment to sustain the African American community. Our Community Recovery Center offers addiction peer services to African American community, but is not limited to. We help anyone coming through the door asking for help. A fellowship hall, events, meeting space, and community recovery meetings. We provide traditional, temporary, and permanent housing and alcohol and drug-free living environments for individuals in recovery. It has taken nearly 30 years for us to establish a foothold, a strong foothold, within Portland's African American community, both in terms of building up our organization's infrastructure and building deep, working foster healing and begin the work. Deep trust within the communities we serve. Trust is essential when working to foster healing and begin the long work of addressing the multi-generational harms of the war on drugs. One of the most important ways we can continue to solidify trust within our community is by showing them that we will always be there to help. Trust also means accountability. We create individual support plans for each of our clients to help keep folks on track towards their goals. Sources of recurring funding, like what Measure 110 is designated to provide, help make that possible. Measure 110 grant funding is helping us maintain and grow our local presence, programs, housing, and other service offerings. Thanks to new funding from Measure 110, we have been able to increase street outreach and transitional housing beds, including the first and only transitional house for African American women in recovery. We have also been able to expand our outreach into Washington County. The impact of our services cannot be overstated. Over 25 years ago, it was forming connections with other people in recovery that gave me the help I needed to begin my own recovery journey. Oregon needs more cultural and linguistically specific services and offer 50 years of enhanced. Oregon needs more culturally and linguistically specific service and offer 50 years of enhancing policies to specifically destroy my community. We must lean into healthcare response and not reinstate failed policies, past policies that are rooted in racism. I urge you to support the policy proposals to expand access to evidence-based, culturally specific, vitally recovery services that saves lives.
Thank you so much. All right, Mr. Garcia.
Okay, hello members of the committee. My name is Jose Luis Garcia. I am the founder of Juntos, and we are part of the Latino Burn in Multnomah County and members of the Oregon Black and Brown Indigenous Advocacy Coalition. Juntos provides outreach and harm reduction navigation services to the Latino indigenous communities in need of substance use recovery support. Juntos also provides behavioral health trainings and safe spaces for Black and Brown indigenous professionals to work, to network, support, and learn from each other. It's our commitment to building a strong workforce that ensures our community has access to culturally and linguistic specific care. For years, the Latino community in Oregon has been facing significant disparities in access to behavioral health services, which demands immediate attention. Culturally and linguistic specific services are not available for my community. These disparities are causing long-term and harmful consequences, leading into health problems, mental health, substance use, violence, crimes, exacerbations of existing social and economic disparities for my community. With the growing population of the Latino community in Oregon, it is crucial to address the gaps in services and ensure that the Latino community has access to resources and services they need to thrive. With Measure 110 funding, Juntos supported the improvement of culturally and linguistic specific services by conducting initiatives that support the needs of the Latino indigenous community. These activities include culturally specific outreach, prevention and harm reduction outreach events, community presentations, behavioral health conferences, distributed life-saving naloxone, and provided direct client assistance such as rent assistance, eviction prevention, basic client needs, groceries, transportation assistance, as well as navigation to treatment, recovery housing, peer services, and recovery support and other recovery supports. These resources were rarely or unavailable or not available at all prior to Measure 110 for my community. The Latino community needs specialized services, and we are just starting to see the positive impact these resources are creating. This is the kind of investment we need to truly address the addiction crisis in our community. I recognize that more treatment is needed, especially for the clients that I serve. I would be happy to meet with coordinated care organizations to collaborate on developing more culturally specific treatment programs to ensure that they are inclusive and truly meet the needs of our community. I am concerned about the proposal that would expand criminal system as a mode of treatment because it will target Black and Brown Indigenous communities first. It will be more expensive, less effective, and more harmful. Please work on expanding services without inflicting harm. A LEAD model, you guys spoke about LEAD. The LEAD model was implemented prior to the pandemic in Multnomah County, and only whites benefited from this program, even though it was intended to divert African Americans. Thank you.
All right, thank you so much. Thank you very much. All right, that is the end of our invited, our arranged panels, I should say, and we're going to now start with the testimony of, and as I said before, we're not going to get to everybody, but I am going to ask that we limit each testimony to 2 minutes of testimony. I'm going to use a timer to make sure that we stay within it. And we're going to get as many people through as possible until 1 p.m. I want to make sure that you know that the record will remain open until 9 a.m. on Wednesday, the 6th, for individuals who are signed up but are unable to testify, for you to add additional written comments if need be, and there will be additional opportunities to appear before this committee. So with that, I believe I saw Mayor Wheeler who signed up. Mayor Wheeler, are you there?
I am here. It says I can't make the camera work, but you know what? I'm not that attractive anyway, so let's just go with it.
Well, we know what you look like, so I think it'll be all right.
I haven't changed much. Chair Lieber, Chair Kropf, members of the committee, thanks for the opportunity to speak briefly on this matter. We definitely appreciate the legislature's action on housing and homelessness in the long session, that you've turned your attention to substance abuse crisis that we all know it's killing too many. It's forcing the people to live and use on the streets. It's hurting small businesses and our overall economy. And frankly, it's making residents and visitors feel unsafe. We're in a crisis in Portland. Earlier this year, Portland City Council passed a resolution and an ordinance related to public consumption of controlled substances. We do not have a desire to criminalize homelessness nor criminalize addiction. The resolution and ordinance were attempts to address decades of disinvestment in sobering and treatment services and facilities across the street. We need those dollars targeted there. But while we're waiting, a significant number of people suffering from addiction are using on the streets without appropriate interventions or care. That leaves other Oregonians feeling unsafe as they encounter drug use, paraphernalia, residue, and toxic fumes in public spaces. We know that the city can't solve these problems without the state. We look forward to engaging with the legislature. First of all, public consumption must be prohibited. We must have the ability to ensure the safety of individuals on our streets, but often public use of controlled substances is making too many feel unsafe. Law enforcement needs to have the ability to prohibit open use of drugs on our sidewalks, streets, and in our public spaces. Right now, we're preempted. We need the preemption lifted. The state versus Hubble further restricts law enforcement. We need that addressed by the legislature as well. And finally, SUD treatment, substance use disorder treatment, and first responder prioritized beds have to be increased. And so we know there's lots of options being considered. All of us, the city of Portland, would support all of those. Thanks for your time. It's an important issue. I look forward to working with you.
Thank you, Mayor. I appreciate it. All right, we're going to call up Sandy Chung next, and then on deck is Ben West. Welcome.
Good afternoon, co-chairs Lieber and Kropf and committee members. My name is Sandy Chung. My pronouns are she and her. I'm the executive director of the ACLU of Oregon. We're a nonprofit, nonpartisan organization dedicated to defending democracy, civil liberties, civil rights with more than 27,000 members statewide. This is the critical question facing you and Oregonians. How does Oregon allocate limited resources effectively and justly to address addiction and community safety? As many experts and people with lived experiences stated today, the data is clear that the criminal system is hugely expensive, ineffective at addressing and preventing drug addiction, and creates barriers to health and healing. They also shared with you many real solutions that Oregonians desperately need today. More treatment, more peer mentorship, more long-term coordinated care, more non-police mobile crisis response units, and much more along the continuum of care. The war on drugs was clear. If we choose to continue spending billions of dollars every year on the criminal system, we do not have enough to support thriving, sufficiently resourced communities in Oregon. Oregon is what we make it. Please help us create an Oregon with thriving communities, not more jails. Thank you.
Thank you so much. All right, Commissioner Ben West, and then Dr. Andrew Mendenhall is on deck. Welcome, Commissioner.
Do I need to push it? No, it's on.
No,
Awesome.
it's on. We're ready.
Terrific. My name is Ben West, Clackamas County Commissioner, Co-Chair Lieber and Co-Chair Kropf, and members of the committee. Thank you so much for this opportunity. This is an issue I'm quite passionate about. Not only am I a Clackamas County Commissioner, but I also am a registered nurse. I've served in multiple capacities. I've been that nurse up all night long with the patient in drug-induced psychosis, and I don't even know if I'm going home safe that night, let alone what's going to happen to my patient or if they're just going to be back in the next few days. I also serve as an officer in the United States Navy, where I also serve as a nurse. I ran for this position because I realized our system is broken. That's why I wanted to get involved in local government in a greater way. I wanted to use my nursing skills to influence the boots on the ground that impact this community. But what we realize in Clackamas County and throughout the metro area is that we are lacking essential tools to actually provide real care and compassion to people. It's not okay in Oregon to watch people slowly commit suicide on the street because they can't get care. I don't think anybody in this room would disagree with me. It's not okay to see the parks that I grew up in no longer available to my own son because they're litter and paraphernalia and they're dangerous and unsafe. It's not okay to have this be our new normal. These are not Oregon values. I would encourage you guys to work closely with your local governments, like your county commissioners. We have local shovel-ready projects like recovery campuses, the whole continuum of care, stabilization centers, building out a web of support in a way that's innovated. Clackamas County's numbers are fantastic. Without the resources we even need, we're still making progress. Look to those on the ground like us, your county commissioners. Let us work with you on how to really work to solve this issue and believe that recovery is possible, not just in my county, but also throughout the state of Oregon. Thank you.
Thank you, Commissioner. All right, Dr. Mendenhall, and then on deck is Commissioner Patty Adair.
Thank you, Co-Chairs Lieber and Kropf, for convening the Joint Committee on Addiction and Community Safety. For the record, my name is Andy Mendenhall. I'm a board-certified family medicine and addiction medicine physician, and I serve as the president and CEO of Central City Concern, Portland's largest homeless, social services, and healthcare not-for-profit organization, and we proudly operate a LEAD program in Clackamas County. The crisis that you are considering in this committee is the result of a siloed system not built to handle substance use disorder, public safety, mental health, and homelessness in a coordinated manner. Instead, the humans suffering from these vulnerable conditions are stuck in a system of chutes and ladders across literally every aspect of behavioral health care, housing, crisis response, and public safety services. Simply put, we do not have enough of the right things, in particular treatment services and shelter and supportive housing. We clearly know through our population health work in partnership with Health Share of Oregon and Care Oregon that these chutes and ladders are expensive, both in terms of human terms and also in terms of how Medicaid dollars are spent. Our public health data show us clearly we are paying catastrophic costs to manage the complications of untreated behavioral health conditions within the Portland region, and this likely applies across the state more broadly. So I want to offer tactically what would benefit public safety in Portland and potentially be a model for other regions across Oregon. First, a specifically designed place for folks to go and to be brought when they are impaired, at risk, and unsafe, particularly folks who don't otherwise have anywhere else to go, folks who live outside. Many are currently and appropriately being served by the front doors of both standard and psychiatric emergency rooms. But we know not everyone who is impaired and at risk first needs to go to a hospital, nor to a jail. This topic is complex, recognizing fentanyl users experience severe withdrawal, as we heard before an hour goes by, and folks with psychosis will still need acute medication administration for their safety.
It's all right. You got 30 more seconds.
Thanks. Some will still need to be transferred to a hospital. Some will need to be civilly committed. The execution of a plan to deliver this type of facility and service suite is not on the shoulders of this committee, nor on Central City Concern, but we're committed to being present in solution-oriented discussions. Thank you so much for your time today.
Thank you very much. Commissioner Adair, and then on deck is Danita Harris.
Good afternoon, Commissioner. This is Patty Adair, Deschutes County Commissioner, Chair Senator Lieber, and Representative Kropf from Bend. I just want to thank you for this opportunity to testify. One of my leading statements is that the leading killer from 18 to 45-year-old is our drug use in America. We have billboards here in Deschutes County, but it's not helping. Every overdose is concussion. The use is spreading. And now we have Trank here, which is making it incredibly difficult, even for the hospitals to overturn this issue, the use. Best Care has had 19 patients a month ago that have passed away from their drug overdoses. Historically, they've only lost one. We've got to do something different. It's just not working. Dr. Corthios actually said that Oregon youth was at the top of the list, and it's not the top we want to be. We want to be at the bottom. We've got to do more education. And one thing I haven't heard today at all is that we in Deschutes County at St. Charles have had 6 fentanyl babies born in 70 days, 6 babies whose lives are forever scarred. What are we doing? What are we doing? Where have we lost our way? These scars and what's happening with our kids that are being raised with drugs in the home. I've heard it from someone. I'm hoping he's going to be able to testify, and I know he's going to write a letter that has firsthand knowledge of that. Please consider changing the possession of a controlled substance from an E violation to an A misdemeanor to compel help and care for those who need it and who seriously must have it sooner rather than later. And then please also prioritize adequate and sustainable funding for Oregon specialty courts. We just recently lost our court. The drug court was really something that was working, and I desperately want to bring it back. Thank you for your attention, and something's got to be done, and you've got a couple of months to do it. So I appreciate this opportunity. Thank you.
Thank you, Commissioner. So Danita Harris is up, and then Commissioner Paul Anders is next.
Chairs Lieber and Kropf, and members of the committee. For the record, my name is Danita Harris. I am the Deputy Director of Movement Building at Imagine Black, where we imagine the alternatives that the Black community deserves and builds the political power to achieve those alternatives. I am also a resident of Salem, Oregon. I do not know anyone personally or professionally that has not been impacted by the war on drugs. Despite decades of data proving that it compromises of failed policies and is used to terrorize Black and brown communities, we continue to pour resources into keeping it and its legacy alive. Well before the economic impacts of COVID, Oregon had declared multiple states of emergency regarding homelessness and drug addiction. However, we failed to actually address the depth of the issues and fully fund any services. The facts are we will never arrest our way out of this crisis. If we could, we would have. Recriminalization, as proposed by some, is just another way to criminalize poverty and homelessness. We shouldn't expect the police to solve social and medical problems like mental health illness and addiction. It's time for solutions that let mental health and drug care professionals actually help people who need and want treatment, instead of implementing controversial policies that disproportionately harm Black and brown communities and our houseless neighbors. We know that harsh drug laws don't prevent drug use, and addiction is higher in 32 states despite the fact that they have harsher drug laws. Locking up people struggling with addiction isn't going to solve the problems that we are facing. We are calling on you to expand access to resources, to stop the misuse of the carceral system, and to reject returning to failed policies. Thank you.
All right, thank you so much, I appreciate it. All right, Commissioner Anders, I hope I pronounced that right, and then Juanita Swartwood is on deck. Thank you. Commissioner. All right, Juanita, I'm gonna go to you now. Okay. We'll come back to you, Commissioner, if you can hear me.
I'm going to read fast.
Okay, thank you so much.
My name is Juanita Swartwood, and I've been a Portland resident for over 50 years. For the last 22, I've lived in the Lentz neighborhood in Southeast Portland. As a retired public participation coordinator from Prosper Portland, I have seen many changes in Portland, and with the passing of Measure 110, a noticeable decline. Thank you for the opportunity to share my story as it relates to consequences surrounding the passing and the failure of this bill. Today, my daughter is with me, her eldest daughter, Emily, and I'd like for you to just see Emily and put a face to what our family has been going through, is the reason I'm here today. Emily, who has high-functioning autism and bipolar disorder, found easily access to meth and various other drugs after moving to Southeast Portland. Portland police responded at least twice where drugs were visible, and we asked if they could arrest her for possession or use. Due to Measure 110, officers could do nothing. By the summer of 23, Emily was fully engulfed in the drug scene, and we would have welcomed police intervention in order to interrupt Emily's destructive cycle. Family intervention, though, wasn't enough. In May 23, we offered her one facility where we could find dual diagnosis treatment, which was in Colorado. She refused to travel so far from family and continued in her addiction. In July 23, Emily was asking for help again, but we could not find a facility who would accept her due to her diagnosis and her dual diagnosis treatment. After realizing there was nowhere to go, Emily again continued in her addiction. With all the promised funding and services, absolutely nothing was available to her here in the state of Oregon. And I'm sorry, may I have a little more time? Go ahead. For now, Emily is on the road to recovery. I'm happy to say that because she made the decision to stop only 2 months ago, and we're hoping that continues. With her mother's guidance, who has a master's, by the way, in special education, to help her navigate this intake system. I will never forget when Emily told me she realized she could not maintain sobriety in Oregon because drugs were readily available to her right outside her door on a continual basis, and sometimes for free. According to the Portland Police Bureau, on December 1st, the narcotics unit reported 277 deadly overdoses since the start of 23. This is a 75% increase over 22. My family could have easily been part of that 75%. And I'm asking you today, how many more deaths does it take to realize this bill does need some modification? And that's what I'm asking for today. This is a personal choice to come here today and ask you for that. And I appreciate the extra time. And that is why I'm a petitioner to fix this bill. So thank you again for allowing me to speak, and I appreciate your help.
Thank you so much, appreciate it.
Quick question, Madam Chair.
Yes, go ahead, quickly.
Where did your daughter treat the last time? Because you talked about her resolving. That's a
good question. Absolutely, she has not been in a treatment facility. We were lucky enough with our family to find intervention with her and help, because my son-in-law is an ICU nurse. My daughter is in special education. We've been helped in another state with mental health services, but not drug rehabilitation. So we're not out of the woods yet.
All right, good luck to you. Thank you so much for coming. Commissioner Shannon, and then on deck is Larry Turner. Commissioner Shannon?
Thank you, Chair and committee, for letting me testify today. I'm not an expert in anything except I've been in recovery for 32 years. Just to qualify a little bit, I took recovery sessions into Two Rivers Correctional Institution in Umatilla DOC facility for 7 years, from 2013 until COVID. I haven't done it since because I became a commissioner and my time's a little short. I've also in the last 6 months gone through CADC certification training. I've completed 5 of the 6 classes. I'm trying to be as open-minded as I can with everything that has been presented today. My concern is that addiction happens really, really rapidly, and recovery happens really, really slow. And I don't think that incarceration is necessarily the answer, but I don't think that recovery is going to be fast enough to get us out of the crisis we're in today. The only two things that I think could work is complete removing the substance from the addict, or removing the addict from the substance. Either one of them is impossible. So I want to focus a little in the last few seconds here on DOC and peer services. The answer to the recovery I've been around has been through peer services, peer support specialists, and I think I haven't heard anything today in the conversation about long-term recovery and how those peers that work in that recovery continue their recovery through that process. I was in a gratitude banquet the other day. There was 2,600 years of sobriety with about 500 people. That's a 5-year average. The sobriety in there was from 56 years to 3 days, and that's how recovery works. We need to really get a good understanding of what successful recovery is and how do we get to that. I could go on and on and on about this, but I'm going to run out of time. But thanks for the opportunity to say something.
Thank you so much, Commissioner. So Larry Turner, and then on deck is Kat and Chad Sewell. Mr. Turner?
Good afternoon, Chair Lieber and esteemed colleagues on the panel. My name is Larry Turner. I am the co-founder and community navigator of Fresh Out community-based reentry program here in Portland, Oregon. We serve primarily African-American individuals who are returning to the community from incarceration. We go inside the prisons, we go inside the jails, we go in the courts, we go in the streets, we go in the hospitals, we go to the houses, we go to parks, we do outreach to the community, and we try to serve this population. Prior to 2019, and us receiving access to care funds through ballot measure 110, we were able to serve only about maybe 100 individuals each year. Since then, and up until this date, we've served over 650 African-American individuals. Out of those 650 individuals, only 4 have returned to jail or prison. There's been a lot of misinformation going on in here. And the state of Oregon was ratified in 1859. African-Americans were barred for coming from the state and residing in the state. And if they came to the state and resided in the state, they would be taken to the town square after 6 months and given 20 lashes. White settlers were encouraged to come to Oregon and were given 600 acres of land upon arrival. This kind of same mentality is going on. Usually what happens in Oregon is, well, whatever say white people say it goes. And so what that means is in blacks, Latinos, and indigenous, especially blacks, are barred or discriminated for making decisions about themselves, about their communities, about their populations. Our community has been displaced. Our community has been disrespected. Our community has been discriminated against until Measure 110 was voted on by the voters. 58% of the voters said they wanted to see something happen different as the impact of the war on drugs had taken effect on our communities. What has done and what has been proven with my program is that Measure 110 is helping us. Decriminalization does not work. We went to Portugal last month. what they talked about in Portugal, the most important thing I heard was that everybody got on the same page, and it took 5.5 to 8 years before they saw any significant changes in what was going on. It took us over 50 years. I've been working in addictions and social services for the past 26 years. It took us 50 years to get to this point where we are right now. So it's not going to happen overnight. And people can come in here with all this misinformation and all the misnomers they want. It took us time to get here. It's going to take us time to get out of it. And if we don't give it time, we can always go back to what's not working. And what's not working is the stuff that happened prior to Measure 110. Thank you for your time.
Thank you, Mr. Turner. All right, Kat and Chad Sewell, are you in? Okay. It's all right. So, Andrew Wilson, and then on deck, Christine Drazen.
Yep, thank you, Co-Chair Lieber and Co-Chair Kropf, and members of the committee for having me here today. My name is Andrew Wilson. I'm the Chief Safety Officer and Executive Director of Safety and Security here at TriMet. TriMet operates transit service in the Tri-County area, and I think you know many Oregonians rely upon us. 1.2 million Oregonians rely upon us for trips they make each week. I'm here on behalf of the agency to share our support for the work this committee is doing to make policy changes to curb what has become an epidemic of rampant public consumption of drugs in our region. As a transit provider, TriMet continues to experience the consequences of a convergence of behavioral health issues, substance use disorder issues, and addiction, as well as homelessness. This is becoming a crisis that hurts not only our riders, but our employees as well. Despite our focus on security and expanded presence on our trains, buses, and platforms, open drug use has become commonplace throughout our system. And this results in dangerous secondhand smoke as well as dangerous behavior on our system. Public transit must be safe for everyone, and particularly for those most vulnerable in our community who are often reliant upon us. So we know that perception is reality, and people see drug use out on the streets. This creates a perception that transit is unsafe. Improving safety and security on transit is TriMet's top priority. We want to be part of the solution, but we need help from the state to ensure that there are tools in place to curtail the ubiquity of drugs on our system. TriMet's current safety and security budget is double what it was in 2020, and we have now twice as many personnel in safety and security positions at 315. We've also created a safety response team where team members connect people to social services, including housing. While TriMet recognizes the importance of a health-centered approach to addressing substance use disorders, we and the communities we serve need help from the state to reclaim our public spaces, including transit systems. I want to thank this committee for leading this effort to ensure that our state is safe and a welcoming place for all. TriMet looks forward to continued partnership with all of you on this effort. Thank you.
All right, thank you so much. Let's see. Christine Drazen, come on up, and then on deck, Kevin Fitz. Welcome.
Thank you.
Welcome back.
Thank you. Good afternoon, co-chairs Lieber and Kropf and members of the committee. For the record, my name is Christine Drazen. I'm the founder of A New Direction. Thank you for the opportunity to be here today. I stand with a majority of Oregonians who agree that we, in fact, do need to repeal Measure 110. I'm calling for the continuation of funding for the modernization of our mental and behavioral health systems within a repeal of the overtly pro-drug approach that was embedded in Measure 110. It is not enough to simply move drug use off of our sidewalks and into public housing and shelters. We must approach this crisis with a commitment to help people whose lives are controlled by addiction, help them get clean and sober. A New Direction is supporting a range of recommendations put forward by the League of Oregon Cities DAs and others. Additionally, after a recent roundtable on addiction, Measure 110, we recommend the following. We must cast a transformative vision for addiction in Oregon that includes in our definition of recovery a goal of prevention and long-term sobriety that does not currently exist in our definition. We must restore consequences, divert kids into treatment, and allow drug confiscation. I understand that is complex. Recent polling revealed that 76% of Oregonians are concerned about hard drugs in our K-12 education system. In a Measure 110 environment, this is an appropriate concern which I share. We must require the Oregon Health Authority to set specific goals for outcomes and audit expenditures to that end. Recently, a former addict in long-term recovery shared these words with me, and I want to leave them with you today. He said, "We are enabling people to death." To escape your hopeless state of mind, you must have a moment of accountability, or there can be no change. We cannot be neutral on drug use in the state of Oregon. It is killing people. With fentanyl on our streets, there is no such thing as recreational drug use anymore. We cannot enable people to death. We must give people their hope back. To do that, we must have accountability and real access to ongoing long-term supports and services. Repeal 110, but modernize our delivery system to respond to the reality of fentanyl, fund prevention, and support programs whose goal is sobriety and long-term recovery. Thank you for your time.
Thank you so much. Kevin? Is Kevin online? Are you online, Kevin? No. Okay, we're going to move on. Janie Gullickson, and then on deck is Dr. Megan Keneally on deck. On deck, Dr. Megan Keneally. Morning or afternoon.
Good afternoon. Am I first or?
Go ahead.
Okay.
Yes, thank you.
Thank you, Chairs Lieber and Kropf and Committee. Thank you for your time and energy investment in this issue. For the record, my name is Janie Gullickson. I am the Executive Director of the Mental Health and Addiction Association of Oregon. We are a peer-run nonprofit based in Portland, Oregon, serving the Tri-County area and direct peer support services, of which you have heard a lot today about the benefits of, as well as, jobs and training in peer services and technical assistance. So because recovery is a long game and recovery begins with hope, I was so happy to hear the commissioner talk about that. That's not only true with substance use disorder, but for our system as well. Our community and our system needs to believe that recovery is possible and to have hope that we can come up with solutions. And those solutions need to be all hands on deck. And you've heard the benefits of peer services. I invited my Behavioral Health Resource Network, Measure 110 funded director of our Tri-County programs. We have Measure 110 funded programs in Washington, Clackamas, and Multnomah County. Again, as you have heard, recovery, the foundations of recovery are health, home, community, and purpose. And the Mental Health and Addiction Association of Oregon staffs 175 people who identify as in mental health and addiction recovery. That's 175 people who may have been doing something different in their communities prior to their recovery. And recovery is a long game that needs to be supported throughout all the connections to care. Heads connected to the body, we need health care. And what I would also like to share is when we think about addiction as criminalization, that is a stigmatizing contagion in the community. We'll think about it as a criminal issue. When we think about it as a public health issue, the community will rally around people like they do with other healthcare conditions and support people to wellness. Thank you.
Thank you. Thank you so much. All right, Keith Wilson, and then on deck is Jackie Yerby.
Chair Lieber, Chair Kropf, committee members. My name is Keith Wilson, and I'm the president and CEO of Titan Freight Systems and a member of the Downtown Portland Behavioral Health Task Force, the group for which I am speaking to you on behalf of today. I recently traveled to Portugal and the Netherlands, which besides Oregon are the only other drug decriminalization jurisdictions in the world, to collaborate with their health leaders, law enforcement, social workers, and politicians to compare the three programs. I have a crucial observation. Even with decriminalization, Portuguese and Dutch authorities prioritize the confiscation of hard drugs in open use. Oregon's law enforcement agencies, unfortunately, do not. If I could advise this committee to do one thing, it would be to provide our law enforcement the power to confiscate all drugs that are openly used. In Portugal and the Netherlands, if a police officer sees the open use of hard drugs, their laws empower the officer to seize the drugs immediately. The most important message they send to their community is that open drug use will not be tolerated. Specifically, in the Netherlands, when an officer is confiscating hard drugs, they will do one of three things. If a personal use amount, they document the user's name and send them on their way. They won't even cite the person. If a misdemeanor amount, they provide a citation and fine. If a felony amount, the user is arrested at that moment. The result of this process is that you will be hard-pressed to find any hard drugs being used openly in the Netherlands or Portugal, which is the opposite of what you will find in Oregon. There's rarely been a walk in downtown Portland where I haven't seen someone smoking from a piece of tinfoil or plunging a needle into their arm or thigh. Nobody, especially kids, should have to witness the tragedy of open drug use on their way to school or the playground. Unfortunately, this tragedy has been normalized and is an all too common occurrence in my city. Please change our laws to enable our police to actively participate in reducing the open use of drugs in our community. Thank you for this opportunity.
All right, thank you so much. All right, Jackie Yerby, and then on deck is Lisa Schroeder.
Co-Chair Lieber, Co-Chair Kropf, members of the committee. For the record, my name is Jackie Yerby, and I use she, her pronouns. And I'm just going to say I am weirdly nervous, given that I used to do this all the time when I was Governor Brown's behavioral health policy advisor, just not in person. I am a staff member of the ACLU of Oregon, but in this testimony, I'm providing my personal thoughts and reflections and not making a statement on behalf of the ACLU of Oregon. Senator Lieber and Representative Noce, when I served as Governor Brown's behavioral health policy advisor, we spent a lot of time together working to transform the behavioral health system. I remain hopeful that our work and the legislature's historic investments, beginning in the 2021 legislative session, will be an inflection point for creating a system that better serves Oregonians. We're at another inflection point. Our addiction crisis has deepened. The anguish of everyone involved impacted by addiction is real. Criminalizing addiction and poverty will only deepen that anguish for people with drug addiction. Even if people are able to access treatment while incarcerated and remain in recovery after their release, they now have a criminal record that will make it almost impossible for them to find a job or find housing. This solution condemns them to poverty and perpetuates the cycles that may have contributed to their addiction in the first place. This solution harms children. This solution disproportionately impacts Black, Brown, and Indigenous Oregonians. That's not a solution. I know that you are all committed to the well-being of Oregonians and of our state. I am deeply grateful that you have taken on this challenge. Please, please look for those solutions that will truly address the addiction crisis over the long term. Solutions that recognize the addiction crisis for the public health issue that it is. I've got two sentences. Solutions that address the root causes of poverty and hopelessness. Solutions that listen to experts in treatment and prevention, including people with lived experience of drug addiction. Thank you.
Thank you. All right, Lisa Schroeder, and on deck is Maylee Browning.
Hi there, my name is Lisa Schroeder. I'm the chef and owner of a business in downtown Portland called Mother's Bistro and Bar, which has been in business for nearly 24 years. We've been victims of vandalism and other property crimes over the years, but nothing like I have seen since the passage of Measure 110. There is a virtual drug supermarket that operates in downtown and other parts of the city. The drugs make people brazen, committing crimes they'd never commit before. The police occasionally come in and clean up a specific area with their superficial presence, and the drug market moves along to another corner. It's like playing the game of whack-a-mole. Sadly, the passage of Measure 110 happened with all the pieces not put in place, and drugs were decriminalized without having a place to send someone looking for recovery. We put the cart before the horse, and we're paying the price. The quality of our citizenry, the quality of life for our citizenry, from the user to the general population, is suffering. I'm therefore begging the legislature to reform, change, or revise Measure 110 so there are consequences for public use and possession of more than a small amount of drugs. I'm saying revise or amend the measure because we need to leave the treatment money in place. We must create a diversion system to compel people into treatment, resulting in an expungement of any criminal record if they seek help, because as we're seeing, voluntary treatment is not working. We need to return to some sort of drug court that can oversee and track the progress of each individual. We must return to minimal criminal charges to allow law enforcement to intervene with what's happening on our streets. The police have zero tools right now, so nothing is being done to stop the use in public, at times leaving people half naked or half dead on the streets. The police throw their hands up and surrender because there's nothing they can do. Though illegal to use publicly, the short-staffed police don't bother this site because nothing comes of it. So nothing is being done about it. We don't have any other infrastructure to deal with the new drugs and increased public use. Until we do, we need to take a step back for the sake of Portland and the state of Oregon. Please amend, revise, or reform Measure 110.
Thank you. All right, Maylee, welcome.
Thank you, Chair Lieber, Chair Kropf, members of the committee. My name is Maylee Browning. I'm the Legislative Director for the Oregon Criminal Defense Lawyers Association, and I'll focus my testimony today on Hubbell, Boyd, and drug delivery. Hubbell is the current case law which overturned Boyd, and Hubbell is not the problem. In addressing large-scale drug dealing, we don't want to create unintended consequences that will harm everyday Oregonians suffering from substance use disorders, and that's what returning to Boyd will do. Sadly, some people with substance use disorders engage in addiction-driven selling. If they weren't in desperate financial circumstances, it's unlikely that they'd be selling drugs. Under Boyd, a first-time addiction-driven seller with no criminal history would be sent to prison. That person would be ineligible for drug treatment before prison. It's straight to prison. And we know that in prison, there's very limited opportunity for drug treatment. Plus, the consequences of a felony conviction just reinforces the addiction cycle. If we're not careful in how we amend Oregon law, we risk inadvertently scooping up these people who suffer from addiction and sell small amounts of drugs, and we treat them the same as large-scale organized crime. We should be working to ensure that people engaged in addiction-driven selling can get treatment in order to break the cycle and help them move forward in our community. Thank you.
All right, thank you so much. I have time for one more, and I'm hoping that Scott Steiner is in here. Thank you so much for being here, Scott.
My name is Scott Steiner. I'm just very grateful to have this opportunity. I appreciate everybody's time here. I'm a firefighter. I've been a firefighter for almost 30 years. And I've heard so much stuff. My mind is swimming with all the stuff that we've talked about today. But one of the things that I wanted to just talk about is I have been on more drug overdoses and I've seen more drug deaths in the last 2 years than I did in the 28 years preceding. That's astounding to me. It's hard to wrap my head around, and I remember these people. I remember the bodies. I remember what happened, and it makes a huge impact. I spend lots of time. I'll spend as much time as I need to with a person on the side of the street. I'll work my phone. I'll make phone calls. I'll do whatever I can do to try to help that person find, because I know that the emergency room is not the right location for them. And if they're ready and they're willing, because 110 said for every Oregonian that wants to get help can get help. Well, that's not true. There's so many roadblocks when I'm on the side of the road, when I'm trying to help somebody, and I'm stuck with no answers. It may be an insurance problem, or maybe, who knows? I have no idea what the issues are. That's for you all to figure out. All I know is when I'm on the side of the road and I'm working and I'm trying to get somebody help and there's no help to be found, it's incredibly frustrating. It's incredibly sad. Me and my crew, we take that back, we talk about it, and I take it home. We've got to figure out what is the solution. I don't know what the solutions are. The complexities are incredible. I hope you all can figure that out. So thank you for your time.
Thank you very much. Well, that is going to conclude our public testimony today. We don't have time for any more. We are going to be meeting, of course, again, and I would welcome you to come and re-sign up. For those who have signed up and were unable to testify, again, you are able to submit testimony up to 9 a.m. on Wednesday, the 6th. So please submit some written testimony. It would be really helpful. I hope this has continued to highlight the complexity of these problems. I will tell you that I do believe that every single person who has testified really wants to find solutions to the problem, which gives me real hope. And we are going to continue to try to find those solutions. So thank you so much, everybody, for being here.
It's good to see you.
And that, I'm going to close the joint committee.